Hello, Dr. Anirban, right? Am I audible to you?
Yes, whatever.
Uh, so we'll start at sharp 7 p.m.
Okay.
Hello, everyone. I am Dr. Arijit Kormakar, head of the Department of Physiology, Mahadevananda Mahavidyalaya. So today, our department has organized one-day international level awareness webinar in observance of World Mental Health Day 2020. So we are very much thankful to our principal sir, Dr. Nayan Kumar Sarkar, for providing us the permission for conducting this awareness webinar. We are also thankful to our all speakers who have voluntarily accepted our invitation for delivering their talks. And we are also thankful to our audiences for participating in this webinar. So, right this moment, I am willing to welcome Dr. Anirban Roy on this platform for delivering his talk.
Thank you. Thank you, Arijit. Uh, after, uh, as Dr. Kormakar has already mentioned, I am going to present my lecture, but I need to present. If I think you need to stop sharing, otherwise I cannot present. Dr. Kormakar,
Yeah,
I think you need to stop sharing, otherwise I cannot present.
so I think I have stopped.
Uh, uh, so everybody is everybody is if- everybody can see.
Yeah,
Yes, sir,
it
you
is
can.
visible to me.
Uh, so today is a special day for us. today the Mental Health Day, uh, World Mental Health Day. It is today's. It is a day when we come together as a to aware people, make people aware of our psychiatric issues, mental health issues, and we can discuss with them how severe it is, how much it is needed to come forward. Actually, every day is a mental health day. It's not that every day is a world mental health day. Mental health day is a separate thing. I know the mental world mental health day to make people more aware of the mental health issues. But still we need a special day because it reminds me us to work specifically on that day, so that the whole world is observing the day, and total they're actually, it becomes a prerogative for us to it's a sort of must for us to present, and it's must for us to make people aware that there is a issue with mental health, and we must be aware of those that thing. I'll come to the point. When is the what is the mental health burden? We may be knowing that there's some people are mentally ill, or some people are mentally unwell, but we are not definite that how severe it is, how much, what are the number of people that suffers from mental illness. Actually, the problem is because we don't come forward with the problem, because there is a taboo. I will come into all those things, why the taboo is, and why the taboo is meant to be diffused. Otherwise, there is if taboo is there, then we will never can perceive the true burden of the mental health issues. Actually, in 2017, there is a throughout the world there is a survey to assess the global mental health disease burden. And in that survey, it is the first result is come in 2018. It shows that 792 million people in the world, that is 10.7% of the people of the world, actually is suffering from mental illness. And most common of them is depression and anxiety. That is that itself at 3.4% of the whole population. And 3.8% is anxiety. And uh, among that 10.7% of the whole population, 99.3% of male and 11.9% of females are affected of mental illness. So it's a big chunk, more than 10%. The issue is more severe in India. Of that same study, the Indian data shows that in India, totally 197.3 million, that is 14.3% people of India have mental disorder, including 3.3% of depression and 3.3% of anxiety disorder. It has just come in February 2020. In Lancet it is published. So it is the Indian mental health disease burden is more than the whole world. It is 14.3% of the whole population. And in India, who estimate that what is the burden? I mean, this is the prevalence, and the burden means what is the loss to the society for that disorder, for that disease. So, who estimates that the burden of mental health problems in the tune of 200 uh, 2443 DALY, means disability adjusted life years. I mean, for life years, I mean, if 1 year, if one person, you know if uh, 2443% are ill and non-functional for that illness for a whole year, then it is daily is 2443. Am I clear? I mean, it is actually the year year lost due to this disorder into the total lives, the number of person that is affected to with it. If the product is coming down to the total loss of the society, total loss of the productivity of the society for that disorder. So this per 1 lakh population, this is like this. And suicide rate is 21.1 in a 1 lakh population. But it is into the WHO says in October 4, 2020, it says that one fourth of the world suffers from mental illness. But treatment is, but the unfortunately the treatment is not accessed. They say that the only the 14.4 2 by 2/3 of the disorder person who suffers from the mental illness never reaches the professionals. And 50% of the high income countries and 85% the LAMIC countries. LAMIC means low and middle income countries. It's according to the WHO data 2012, it is a big two-third never reaches professional. And it is already we know that good mental health is critical in functioning in the society at the best of the time, and it must be front and center of the every kind of country's response to and recovery from COVID-19 pandemic. So in COVID-19 pandemic, when the 2020 people are suffering from the COVID-19 pandemic, mental health and well-being of the whole societies has been severely impacted by the crisis, and a priority being addressed urgently. The problem is in COVID pandemic, we all know that the disorder is not lethal, is definitely not lethal. But the problem is we never know in whom it will be lethal. So we are all cautious and we are all very skeptical. So the fear is very important. The infodemic, we are saying that we are reading lot about pandemic, and we are getting anxious, forgetting, in going out we are having difficulty. And some people are doing the contrary. They're so bold, they're frustrated in thinking about this thing. They're so bold and going out in going out at looming large and doing everything as a normally. That is also very problematic, because there is a problem, and COVID-19 pandemic is actually devastated the whole world, and more than a lakh already died in India only. So and about the world, it's a different thing. So lakhs of people are dying. So we must be cautious, but it must be, we must be cautious. But we all also understand the fear is also very important thing. And also there is a loss of, one is disorder and another is loss of jobs, loss of livelihood, those things, loss of our normal lifestyle, a loss of normal social interaction, friendship, schooling, everything is lost. So that there is a large line of losses. So that loss, the sense of loss is actually is very difficult. And to deal with it, to deal with this loss, we must be have a very good mental health. But the problem is that even if it is very so important in important aspect, I think only 3% of the world budget is spent in maybe in high income countries, on advanced countries it is 5%, and it is developing on underdeveloped countries it is 1%. India is less than 2%. Is precisely is 1.6% of the burden is spent on health. And of that health burden, of that health budget, 0.05% is spent on mental health. So it's very difficult for the underdeveloped countries like India, doing it's a developing phase. So we must be aware of this thing. And they're saying that there is a 16 trillion cumulative loss of the years, of the 2010, in this 20 years, due to non-redressal of mental health. Total 16 trillion money is lost. So it's a big amount. And actually if you invest, it's a high investment, but return is also very high. I mean, if you spend $1 in this mental health, it is actually proved that $4 the society gains from the good mental health of the persons, that is his the money is invested on more investment and greater access. So our theme of this year is more investment and greater access of the mental health care. So what is the barrier? We must understand what is the barrier. Barriers are one is stigma. Stigma is what? Stigma is the act of seeing one in a negative way or discriminating against because of his or her mental illness. What is the causes? Causes is lack of awareness, lack of education, lack of lack of awareness is very important. Lack of education about the disease and the in general. Lack of perception, proper perception of the this disorder. The nature and complication of the mental illness. That is the odd behavior and violence. It is kind of social oddities are there. So hence we are very we are very skeptical about the what is the this thing of the mental illness. So financial impact has a long time lack of functionality. Financial impact due to the long time lack of functionality is very important, also because of the stigma. Because in this cases, I mean, in diabetic patients also, the treatment continues for a long time. But mental illness, what its treatment continues for a long time, but unfortunately the persons are not that much functional enough and not by earning. I think financial are if the person earn financially, we are not really bothered of what he is doing. So if the person is not doing his function, is earning, studying, otherwise if they're doing everything, we are all okay with it. But if their loss of functionality is there, main function is a person is income. It is that if that is problematic, then it is we are very we the disease is bound to be get stigmatized, and here the same situation happens. And but what there is some improvement. Previously what used to happen, the there is a lot of side effects of medications, or those things are there. So there is a sense in the society that the okay, psychiatric medication is sort of debilitating, and if you start medication, you cannot the person is not the person before. So that is not the case now. In most of the situations, actually the treatment improvement and improved long term functionality is there. More stress on biological model and intrusion of the mainstream medical stream. And there is a currently, previously what used to happen, you used to happen, the psychiatric is actually even the doctors, even the general medical doctors have an idea that psychiatry, oh, I don't know, that is a separate thing. But currently there is a I mean there's a drive where the we psychiatry is being incorporated. It's not yet incorporated fully, but it is in the process of being incorporated in the MBBS course, so that everybody has a clear idea that what they are dealing with. Psychiatry is, there's a lot of biological model, and there is a psychosocial model also. So the biology biopsychosocial models are there. So there is a lot of neurological research and all those things are there. And we have understood most of the situation, that where the mind, what the functioning of the mind is, mind starts, it generally starts from on the brain, prefrontal cortex, limbic system, those part of the brain. When the neurology deals with the motor parts of the brain, motor functionality of the brain, psychiatry is dealing with the prefrontal cortex, the neocortical side of the brain. And we can think with thought, attention, memory, those logic, and social sense, those parts, and behavior, those parts are deal with the psychiatry. It's all in the brain now. But this it's a process, but we have a still long way to go. With a long way to go to reach the when the we can, everybody can discuss with in last few years, last few days, actually in last month, actually I was presenting in a college program, in this kind of college program, where the people, actually one lady is actually came up spontaneously and told that, see, I am your patient, and I was being ready now. I was so happy that a person to say this, to get over this taboo, and get over this stigma and come in forefront, and to tell that okay, I was a psychiatry patient now, before, and I was still on medication, but I'm doing fine, and actually I'm doing very well in this course and in this college. So it's really needs a guard, and I felt so hopeful that our future is so bright. So people are coming up with so brightly, so clearly. So that's our future. So our this is mental health for all, greater investment and greater access. So the World Mental Health Day is 10th October, the International Day for Global and Education, Awareness and Advocacy against the social stigma. This it was first celebrated in 1982, and first by the World Federation of Mental Health. You see the logo behind the in the background of the slides of this slide. This is the logo of World Federation of Mental Health. It is a mental health organization for members and contacts with the more than 150 countries, and it is also supported this mental health. This is supported by who? WFH is also NGO. It is started in 1948, and it is but the Mental Health Day as a first had a theme in the 1984. Before that, it didn't have any theme, but this time the theme is greater investment and greater access. That means we need to invest more in mental health, so that the more people of the more general people, or the people with mental illness, have access to the country. Huh?
Good evening,
So,
sir. Hello.
hello. Yeah.
I have a doubt.
Yeah.
Sir, right now we were talking about the improvements in the treatment part of the medicines just before. So,
Ah.
but I have noticed that as we go on taking the medicines, we get used to it. Like if we are giving sleeping pills, later on
Yeah.
we are unable to sleep without them, and
Oh,
eventually doses have to be increased. So, is there any way to get out of this?
no, see, there is two things. There. One is that definitely. Actually, the sound is echoing. Hello,
Yes, sir.
am I audible? Am I audible?
Yes, sir.
The thing is, see, the addiction, the sleeping pills. If you call sleeping pills, that is Lonazep, or
Sorry
clonazepam,
to interrupt,
or
Dr. Anirban.
yes.
Can Dr. Akshay mute yourself?
Yeah, Dr. Akshay, please mute yourself.
Yes, ma'am.
Hello. Yeah. The thing is, now the if you sleeping pills, if you say your sleeping pills definitely have a addiction potential. Sleeping pills means benzodiazepines, phenobarbital, those kind of specific benzodiazepines, which we call, that have a addiction potential, and that's why we use it sparingly. But other things, now see, if we if we give some medication if we give some medication, uh, that we give due to some symptoms. If the medication, if you withdraw, then the symptom will again recur, because this is a long time symptom. Like see the situation that when you have you have anti-diabetic medication, and you are having diabetic. You started anti-diabetic medication. Your diabetes is normal. Your diabetes is your blood sugar is within control. If we withdraw the diabetic medication at that point of time, what will happen? You'll again have the same level of diabetic mellitus, with the same level of you know uh, same level of blood glucose. Here it is the same thing happen. Here it is a systemic problem, and we are prescribing medication for certain amount to address certain psychiatric symptoms. Now, if we withdraw the medication without the doctor's advice, or if we when we withdraw medication, in some cases we can withdraw, but that also depends on some symptoms. But the problem is, because there is a taboo, when the person gets better, the first thing they want to do it stopped the medication, because they feel the medication is the most dangerous thing they are having. When they are doing well now, they must stop the medication first. Then they will somehow, they don't have an idea. They feel that if you go to the doctor, doctor will continue and continue the medication, so we must stop it. So what happens actually in that situation, it is prematurely we're stopping, so the problems again comes back. And there is there is a bridge concept, there is a bridge concept. Mind is a bridge. So there are lot of heavy trucks goes on, uh, heavy truck goes over it. There is a crack somewhere. There is some, if we give some, supportive, these things, a supportive column, we have developed certain supportive column, and we allow the trucks to go on. What will happen, either what will happen, that you have to, like this, like this Tala bridge, we have to stop every heavy truck, so you should avoid stresses, everything. Or if the situation is not so bad, what we can do, we can allow the trucks to go on, but you have the supportive column in between. But if we don't allow the bridge to settle, or bridge to I mean a cementing to, a concrete to properly strengthen, and we just take away the supportive column, what will happen, the same place will break again. We have the same weightage, and same place will break again. And if you break the same place repeatedly, at some point of time, it will be another Tala bridge. We will never repair it. We have to completely break it and do it again. But unfortunately, in mental, in a person's mind, we cannot completely break the mind and do it again. So the problem is, we just keep the person in a debilitating way. So that is, I think, is a problematic thing. I mean, I must understand, I must tell you that we must feel that no doctor is going to continue you on medication for long time. So you can, if you can, any problem with the medication, you can tell the doctor, no, see that I am having this kind of problems with medication. I'm sure the doctor will definitely help you reducing the medication, and you see that what list amount of medication we can give. But if you stop the medication on your own, then the thing, what will happen, the what actually you have told, that the again actually it will, having the same problem and the same medication. And you will, the problem is the most difficult problem. What will happen, no, if this kind of repetition happen, that you lose hope. If once a psychiatric problem happen, you feel that, okay, I am having medication, I'll get better. Once you get better, you stop medication. Then what happen, it again comes back to you. Then you have a feeling that one is psychiatrically, psychologically, you feel that it's bad. You have, again, it's come back. Your neurologically, your systems, your synapses have some problem. It is broken down, as I have already told. But the problem again is comes that, no, you feel bad, that, okay, I have tried so much, so hard, but it's again, I have in psychiatrically, some problems are there. So should it continue for long? Should it continue new permanently? That kind of problem actually haunts us. That is a big problem I felt. So I will again, now I will going to have some FAQ. Like, what is mental illness? Is it completely functional? It's not function. And the people have an idea that, the person, some people have idea. I'm not saying all people have idea, but some people have the idea that, people are doing it intentionally. If he or she intends to not to do it, he will not to do it. I mean, it is completely functional, depends on function. It is not so actually. Mental illness is a definite illness, and there is, how, if it is completely functional, you feel, you are a science student, so how you can also understand how the drugs will act. Drugs will act on some substrates, on some neurons, on some synapses. So there is, if the drugs actually responses, so there must be some biological basis, but obviously there is some psychosocial basis also. We need to be cautious of that also. It's not that, hope is big thing. If you lose hope and continuously feel that I will not be okay again, that then it is very difficult for you to get better. So psychosocial part is very important, but yes, but there is a biological part, and there should not be critical comments. It's very important. And the problem happens every time there is a critical comment, because the family also loses hope. The family also feels that he is not that good, so they expect less. And the person, the psychiatric illness, the ill person also expects less of himself or herself. That's the problem. That is that part has to be discussed and dealt with. And is he doing it intentionally? No, it's a I mean, I already told that. Why me on my relative? It's very important, and there is a lot of is especially in developmental disorder kid. I think Dr. Preeti will discuss today. She's a DM in child psychiatry like me. She's my senior, so she will discuss with me this thing. She is relative. This is definitely there is a genetic component. Definitely there is a genetic component, no doubt about that. That it is familial, but that doesn't mean that there is a one person in the family is there, so every person will have the same chance. There is a some there is lot of familial arborizing this thing. I have seen there is both the parents are completely normal. The if, is actually they have some risk gene, some protective gene. Both genes have worked well to you know give a give a standard good product, and they are functioning completely normal. If they have, but the problem is their offspring have their they have risk gene from both of them, and having difficulty because they don't have protective gene, they have risk gene. So all of us have some risk gene of psychiatric disorder. All of us have some risk gene, some protective gene. If we have the risk gene is more, then we have some issues, could be some issues. If the protective gene is more, it's actually it's we get, so we actually survive. But the problem is, if the stress is more, if the stress is more, then the protective gene cannot control us. So there is a stress diathesis model is there. So if there is a diathesis, there is a tendency to have disorder. But if the stress is more, then there is a discussion on stress diathesis also on the later part of it. So there is a diath. If the stress is more, then our our protective component, our protective psychological or genetic endowment cannot control the risk problems. So we have some psychiatric issues. It depends on the strength of our diathesis, our tendency, and the strength of the disorder. We That depends on how long it will continue, and how if it is get better, or it can be the drugs can be stopped. Those things depends on those part. The what is the cause, how it is, how the what is the causation, the formulation of the disorder. It's not the disorder per se, it's not the depression, it's not the anxiety, all depression, all schizophrenia, all psychosis are not same. That depends on the person to person, that the prognosis varies on person to person. So this is very thing. So it is curable. Will it get better ever? Yes, it is. I also told, if I start, can I stop the medication? I saw that yes, we can stop sometime. How long medication will continue? It's difficult to say, depends on the person to person. uh, it's not it's not depend on you are weak or not. It depends on, it actually it needs a lot of courage to come out to say that I am psychiatrically not okay. No, just not a good bash, all right. No, it's not like that. So I already told that there's a biopsychosocial model is there. Share with friends and relatives, consult with expert. Recognizing one's problem is the strength of the character. Solution problem identification. Prevention is better. So what you want to do? There is a lot of is you all know this. Take rest and exercise regularly. Spend some me time, we time, fun time. Follow your passion. Encourage hobbies. Those things we all know. That positive side of it. I'll not go into details of that. So there is a we also there is a COVID-19 in mental health is very important. It promotes mental health actually promotes immunity, so it's more important in this COVID time. Stress, anxiety, depression is increased. Suicide rate is impacted. Psychosis or viral related mental disorders is could be possible, but it is not sure as of now. Suicide rates obviously increased, but we also don't know when the because it's due to the biological part of the COVID pandemic or the other things, the job loss, the whole lots of losses are there, could be that part also important. So ultimate measure of a man is not where they stands for the moments of comfort. So what is stand of time as challenge and controversy. So spread mental health and promote resilience. I think I have crossed my time limit, but the problem is there was in between some questions that we have to discuss. That's probably, I'm sorry for that. Thank you.
Okay, sir. Thank you very much. No issue. So we are very much thankful to you for delivering a nice presentation to all of us, and it was very much informative. So thank you for being with us.
Thank
So
you.
now
Thank you.
I would like to request Dr. Vidya Jadhav to come on the platform and present this yourself. Dr. Anil Rai, you must keep your microphone off.
Some can everyone mute
Hello.
themselves, please? Dr. Anirban, can you please mute yourself?
শোনো না
Dr. Anil.
Yeah, it has been done, ma'am.
Okay,
Please.
is my screen been seen?
Yeah.
Okay. Shubha Sandhya and a very good evening to everyone. I'm once again thankful to Mahadevananda Mahavidyalaya Physiology Department and Dr. Arijit Karmarkar for once again believing in me and giving me this platform to present myself. I am Dr. Vidya Kaushal Jadhav. I'm a pediatrician and an international board certified lactation consultant, IBCLC, and I practice in Mumbai. So today, as we are celebrating the World Mental Health Day, but unfortunately, mental health issues aren't openly discussed and considered as stigma, as is rightly discussed by Dr. Anirban Ray in his previous talk. So actually, it needs to be addressed on a bigger platform like this. And so I take this opportunity to present my topic, which is maternal mental health and breastfeeding. So what are the different types of maternal mental issues during pregnancy and post-delivery, and how effective is breastfeeding to overcome or to some extent reduce the risk of maternal mental disorders. As we all know, physical health is important, but mental health is equally important for everyone, and so is for the mother who is pregnant or who is uh, post-delivery, lactating mother. So before I start my presentation, I disclaim that this presentation has no conflicts of interest. Now, maternal mental illnesses is covered by a term which is known as perinatal mood and anxiety disorder, also known as PMAD. It is related to the mood and anxiety symptoms that occur during pregnancy or within 12 months, that is 1 year after the delivery. Typically, it is triggered by some imbalance in the brain chemistry, which may be caused by combination of the following: It could be genetic, it could be life stress, it could be trauma, drug abuse, family history. Now it is further divided into disorders which are related to pregnancy during the entire period of pregnancy and the disorders which are related post-delivery, also known as postpartum. So first, let's see what are the disorders which are related to pregnancy. So it's a depression during pregnancy, also known as perinatal depression, because it covers the depression during pregnancy and within a year after delivery. Second is grief from pregnancy loss. Pregnancy loss at any point during the pregnancy is shocking and devastating event, not only to the mother but the entire family, which can lead to sadness, anger, guilt, and depression in the mother and the immediate family members. Grief from infertility. We all know the infertility rates are rising, and this type of disorder is seen in almost 10 to 15% of couples of the reproductive age. The second disorder is the one which is related to the postpartum, post delivery mothers. So, here the milder form, more commonly seen, is the postpartum blues or the baby blues. This is seen in around 50 to 85% of women, and it is usually self limited. So, it lasts around 1 to 3 weeks postpartum. But if the symptoms aggravate and if it is prolonged, the duration of illness is prolonged, then it may be classified into postpartum depression. So it is more severe condition, increased severity and duration of symptoms seen in up to 10% post-delivery mothers and emerges over the first 2 to 3 months after birth. Second type is the postpartum anxiety disorder, PAD, seen in approximately 6% pregnant and around 10% of postpartum women. The symptoms may be anxiety related and sometimes they overlap with the depression symptoms. So we need to be aware about it. Postpartum psychosis is the third one, which is a very rare illness compared to the first two, postpartum depression and anxiety disorders, and is seen in only 1 to 2 out of the 1,000 deliveries. So the percentage comes to zero point 0.1 to zero point 0.2 of all the births. It is sudden in onset and mostly within first 2 weeks postpartum. Others less common disorders are postpartum panic disorder, which is a type of anxiety disorder, and it has recurrent panic attacks are seen in this disorder. Postpartum obsessive compulsive disorder, most misunderstood and misdiagnosed, seen in 3 to 5% of new mothers and also in some new fathers. And here they are obsessed. They keep on repeating. The name itself suggests the symptoms. They keep on repeating certain things. Even they know they have done it previously, they'll do it again and again and again. The next is post traumatic stress disorder, PTSD, experienced by approximately 9% women after birth and most often caused by real or a perceived trauma, which could be a prolapse cord during delivery, unplanned cesarean section, vacuum or forceps delivery requirement, baby need to be shifted in the NICU, lack of support during the delivery or post delivery, previous trauma like rape or sexual abuse in the mother, severe physical complications or injury which are related to pregnancy or birth like severe postpartum hemorrhage, excessive blood loss, unexplained hysterectomy, removal of uterus during course of delivery, severe preeclampsia or eclampsia, extremely high blood pressure during pregnancy or delivery, third and fourth degree perineal tear during the normal vaginal delivery, and also the heart diseases. Now we know that perinatal mood and anxiety disorders are extremely common, seen in 15 to 20% of new mothers. Of this, the most common and the most studied is the postpartum depression or PPD. It is estimated figure is 10 to 20% of all new mothers. And now recent research show an increasing percentage, that is 15 to 25% new mothers have PPD. Now, what the partial explanation to this is, this could be due to increased surveillance, increased awareness, resulting in professional identifying more cases. So we are more aware about the symptoms which are possible in the mothers during pregnancy or post delivery. But the second reason it could be possibly that more mothers are really getting depressed because of isolation, lack of support, history of abuse or other trauma, return back to work almost immediately after birth. So we need to differentiate between the milder baby blues or the postpartum blues and the severe form of postpartum depression. So the baby blues are seen in more number of women, 50 to 85%. They occur in the first 2 weeks post delivery, and they're self-limited usually. The symptoms are seen are irritability, anxiety, fluctuation in the mood. This is mild and occasional, not considered psychiatric disorder. But when this aggravates, the symptoms like excessive guilt, anxiety, depressed mood, insomnia, that is no sleep, or hypersomnia, excessive sleep, suicidal thoughts, and fatigue. Now, here the fatigue can be due to some underlying medical disorder. So, one needs to rule out anemia because it is very common in pregnant and post delivery mothers. Second is thyroid, hypothyroidism can also lead to fatigue, and vitamin D deficiency. So, this certain medical illnesses need to be ruled out before diagnosing it to be as postpartum depression. It is moderate to severe in nature and it is prolonged. So it is seen in the first 2 to 3 months post delivery and seen in 10 to 20% of mothers in the first year after birth. Now, there are certain risk factors. If we know the risk factors, we can identify this mothers earlier. So, what are these? It could be biological, it could be environmental. So, personal and a family history of mental illnesses, which could include but not limited to depression, anxiety, and postpartum depression. It could be a traumatic pregnancy or a birth. It could be difficult experiences around the pregnancy and during the birth, domestic violence, which could be physical, sexual, or other abuse, traumatic childhood, stress of any kind, lack of social support. And sometimes it is said to be associated with type A personality and who have very low self esteem. Certain medical conditions are also associated as a risk factor for mental illnesses, and this could be something like chronic illnesses and even surgeries. So it could be stroke, heart disease, chronic pain of any origin, multiple sclerosis, hypothyroidism, diabetes, other endocrine disorders, hormonal imbalances, HIV, cancer. Okay, so anything which is causing prolonged pain, illness, or stress. A very important slide because we all need to know the symptoms, how the patient present, so how to identify them earlier. So this is most common symptom here is anxiety and overwhelming. So they are not always depressed, sad, alone. They could be anxious, they could be nervous, they could be always worried about something. Okay, so because too many women do not seek help because they assume that they aren't depressed because they don't show signs of depression like sadness, crying, less loss of appetite. So they don't seek medical help. So awareness about the symptoms, not for the person suffering from the illness, but by the caregivers, by the family members, by the friends and the society should be aware about the symptoms. Other common symptoms are feeling of helplessness and or hopelessness, difficulty in making decisions, so they depend upon others to decide about even minor things. Changes in sleeping and or eating patterns. Increased sleep, no sleep, increased appetite, loss of appetite, isolation, withdrawal from the community and the loved ones, frequent feeling that I can't do this. It is impossible for me to do this. Not feeling like self, intrusive thoughts, images, fear of harm coming to the baby that the mom can't stop, even though she knows that it is not real, irritable, impatient, lot of anger, difficulty in concentrating, difficulty attaching and bonding with her own baby, and in most serious case, seeing, hearing, or feeling things that are not really there, which we all know is termed as hallucination. So there is nothing around, no person around, but the mother can see somebody around. She can hear somebody around when nobody is around. And the other one is beliefs that are not based on reality. That is called as delusions. So if there is a robe lying down in the room, she might perceive it as a snake and get anxious, get panicked. So this is known as delusion, what is not there or what is there, and that is disbelief. So one may experience either all of the symptoms or only a few. No matter which symptoms or illnesses, mother or the caregiver should know that early diagnosis and prompt treatment will help the mother. Now, let's see how breastfeeding and postpartum depression are related. So initially, it was thought that a mother who has mental illnesses will, needs to take rest, need to take her antidepressant medications regularly, and so she doesn't have to be a super mom. She can nourish her baby with formula feeds because she needs to sleep well, take care of herself, and that is important for her to heal. Also, the medications may transfer to the baby through the breast milk. So, to achieve all this, what the mother was expected to do was to stop breastfeeding. Now, here, as a lactation consultant, I owe a great debt of gratitude to clinical pharmacologist Dr. Thomas Hale. He has done a lot of research and he has written a book which says which all medications can be used safely in a breastfeeding mother. And from this, most of the antidepressants are found to be safe to be used while breastfeeding. So, mother can continue breastfeeding if she wishes to. But there are certain mothers who do not want to take antidepressants. So such mothers has led to next major change in the postpartum depression or any mental illness field, that is the use of alternative treatment in the management. So what are these? Exercise, bright light therapy, omega-3 fatty acid supplements, St. John's wort is a herbal medication, psychotherapy. Now what is exercise, bright light therapy, St. John's wort, how they work? They increase a chemical in the brain known as serotonin. This serotonin is a feel good chemical. It elevates the mood of the mother. It also decreases the immune system chemicals that are known to worsen depression. Secondly, the omega 3 fatty acid is known to be anti inflammatory. We'll discuss this in little detail in further slides. Psychotherapy itself alone is quite effective. So why we need to know about the alternative treatments? Because mother should have lot of choice and they should be discussed with the mother. Most of the time, the mothers are just offered only antidepressant. And studies have shown that only 28% of mother was still continuing with the antidepressant treatment at 3 months from starting the therapy. So there are very high rates of non-compliance with the antidepressant. Thus, always discuss other options with the mother before starting medication so she can choose at least one or a combination to continue her treatment. And follow up is very, very important. So, what is the role of breastfeeding in protecting mother's mental health? Research shows that breastfeeding and depression intersect in some interesting and surprising ways. Breastfeeding does not deplete mothers, nor does it cause depression. Breastfeeding and stress. Let's see what does it do to stress. So whenever there is stress, body responds by causing inflammation. And the inflammatory molecules that cause inflammation lead to depression. But only at a very high levels they are known to trigger depression as per the research. Now here breastfeeding if continued specifically acts as an anti-inflammatory agent. When inflammation levels are lowered because of continued breastfeeding, the risk of depression also goes down. This is one way that breastfeeding protects women's health throughout their lives. Besides, it also lowers the risk of disease such as heart disease and diabetes. Now, how does it affect the sleep of the mother? So, does breastfeeding mother get less sleep? Yes, that is a general concept. But the opposite has been proved by research. It says that breastfeeding mothers get more sleep. It turned out that biggest effect were for exclusively breastfeeding mothers. Exclusively breastfeeding mothers are those who only breastfeed the baby as a nourishment, as a source of nourishment. And mixed feeding mothers are those who breastfeed partially and partially feed the baby with formula feeds. So research indicates that there is something physiologically different about exclusively breastfeeding mother than mixed feeding mother. Mothers who are mixed feeding may be sleeping less and also getting less of the stress reducing effects of exclusive breastfeeding. Exclusively breastfeeding mothers sleep more overall, even though they wake up more often, and the amount of extra sleep is only about 20 minutes or more or so, and it's probably enough to make a difference on the reports which followed. So, what was this study? It was done by Kathleen Kengi Tackett. She is a PhD in IBCLC, and along with Thomas Hale and Zheng Kong, the effect of feeding method on sleep duration, maternal well-being, and postpartum depression. And it was studied in a sample population of 6,410
Dr.
mothers.
Ganu, sorry for
Yes.
interrupting you. Please, you need to present your slide again.
Which one?
Your presentation. You need to share your presentation again.
Again,
Yeah.
is it visible now?
No, madam.
Okay.
We can see you, madam, but
Yeah, so,
Presentation is not
yeah,
visible.
just 2 minutes. Let me give.
Okay.
Now is it visible?
Yeah.
Yes, ma'am.
So should I start from the same slide?
Yes.
Okay. So I was on this we were discussing regarding sleep in a breastfeeding mother. So a mother who is exclusively breastfeeding the baby gets little more sleep as compared to those who are mixed feeding or formula feeding the baby. Now this has been proved by certain researchers. So one of this is done by Kathleen Kendall Tackett. She's an IBCLC. Along with the colleagues, she studied the effect of feeding method on sleep duration, maternal well-being, and postpartum depression. And the sample population was 6,410 mothers of infants. Age group was between 0 months to 12 months. So, what were the findings? It revealed that women who were breastfeeding reported significantly more hours of sleep, better physical health, more energy, and lower rates of depression than the mothers who were mixed feeding or formula feeding. So, further, there were no significant difference on any measure between mixed and the formula feeding mothers, which suggested that breastfeeding is a qualitatively different experience than even mixed feeding. So, I present few charts of their research. The first one is showing the hours of sleep a mother gets. Breastfeeding mother gets more hours of sleep as compared to the mixed and formula feeding mother. The second chart shows the mother's daily energy. Again, it is more in the mother who is breastfeeding as compared to those who are mixed or formula feeding. The rate of depression is also the lowest in a breastfeeding mother as compared to those in the mixed and formula feeding mothers. There was another study which was done which compared breastfeeding and a history of previous sexual assault. So, what did that study said? So, here there are two groups. Sample population was there: one with a history of sexual assault, and one mothers without a history of sexual assault. So, this graph shows the upper line is the hours of mother sleep. The upper line is that of the upper red line is that of the mothers who were exclusively breastfeeding, and definitely in both the groups, whether they had faced a sexual assault or they had not, they were getting more sleep if they were exclusively breastfeeding their baby as compared to those who were doing mixed feeding or formula feeding. Similarly, for depression rate, it was again lower. The red line is the mothers who were exclusively breastfeeding. And so in both the groups, it was lowest rate in exclusively breastfeeding mothers compared to those this is the upper zone, which is a mixed and the formula feeding mothers. Again, the anger and the irritability rate was lowest in the breastfeeding mother. This is a breastfeeding mother in both groups, no sexual assault and sexual assault, and very high mixed and formula feeding mothers. So, so does that mean there is no benefit for a mixed feeding mother? Not at all. She does benefit. So clearly, one must understand that breastfeeding is good no matter how much a mother can or is able to do it. She benefits from whatever breastfeeding she is doing, and her baby benefits too. Need is to understand that mixed feeding mothers may not get the entire stress reducing benefit that a exclusively breastfeeding mother gets, and we should support such a mother accordingly. When mother is depressed and if she is breastfeeding, she needs to support, and if she needs support, and if she indicates in spite of other around her telling her to stop breastfeeding, she wants to continue breastfeeding. As a lactation consultant, as a physician, as a treating psychiatrist, one should support her in all ways. Now, how does the depression in mother affect the baby? So, mother's mental health is not only crucial for herself but also for her baby. A depressed or anxious mother may not be able to provide the nurturing care a baby needs to grow and thrive well. She is less likely to read, to cuddle with and interact with her baby, thus putting the baby at risk of number of health issues like failure to thrive or failure to grow, delayed development is delayed, difficulty in sleep, behavioral and emotional problems later in life, and learning problems. So, this is a theory known as a psychoneuroimmunological theory, which says that all the risk factors, whether it be stress, sleep disturbance, pain, psychological trauma, history of abuse or trauma, the underlying thing is inflammation. So the inflammation underlies all this risk factor. And pure filler women are especially vulnerable because the inflammation levels are significantly high during the last trimester of pregnancy, a time when women are also at a high risk of depression. So what happens whenever a mother is stressed? It could be because of pain, it could be because of sleep disturbance, it could be because of some psychological trauma, some physical abuse. We all know what happens when we are stressed. A hormone is released from the hypothalamus, which is corticotropin releasing hormone. It stimulates the pituitary gland in the brain to release adrenocorticotropic hormone, which acts on the adrenal gland to release the steroids, also known as the cortisols. So this steroids in a normal level will help to heal the body, to heal the inflammation, to heal the stress. But if the release of cortisol is imbalanced, it is more than required. It can counter effect by weakening the immune system, can cause heart disease, can lead to high blood pressure, high blood sugar, digestive issue, nerve problems, and last but not the least, the topic for today, anxiety, depression, and headache. So imbalance in this whole system can also affect the or act as a risk factor for the mother to undergo mental illnesses. So, how do we prevent and treat after we know about this PNI approach? So, two important prevention and treatment modes. One is to reduce the maternal stress, encourage mother to breastfeed, as we know it is anti-inflammatory. Support ongoing breastfeeding as it protects the mother's mood. Neuroendocrinology of the breastfeeding mothers down regulates the stress response and thus protects the breastfeeding mother and directs her towards milk production, conservation of energy, and the nurturing behavior towards her baby. Exclusive breastfeeding also raises the effectiveness of mother's immune system, which was found to be reduced in formula feeding mothers at 4 to 6 weeks postpartum study. Breastfeeding reduces stress not only in the mothers but also in the babies whose mothers are suffering from depression. So there was a study done where EEG was done on these babies, and all the EEGs were found to be normal. So breastfeeding protects the baby from maternal depression. Breastfeeding reduces stress, protects mother's mood, so mother's inflammatory system is not activated and the risk of depression is diminished. Now here the drawback or caveat is that the breastfeeding should be going well. The mother should not be facing breastfeeding issues like painful breastfeeding. Again, pain here will trigger depression in mother because the underlying cause is inflammation. So this should also be taken care that if a mother is breastfeeding, she should be doing it very well without any difficulty. The second mode of management is reducing the inflammation. Psychological, physical stressors are risk factor for depression as they increase inflammation. So the long chain omega-3 fatty acids, anti-inflammatory properties, reduce pro-inflammatory cytokines, increase anti-inflammatory cytokines, and thus reduce the risk of depression and other diseases related to chronic inflammation. Increase efficacy when given with medications, that is the antidepressant psychiatric medications as compared to placebo. Again, the dose has to be calibrated properly for proper effect. DHA, when given to mother in the perinatal period during pregnancy or postpartum, the mother stores, because here mother stores are depleted because it is used up by the growing fetus for brain and vision development. So mothers are in increased risk of inflammation and depression. Mothers with good level of DHA are also present. This DHA also is found in the breast milk, which causes the baby to have more mature CNS because DHA is required for brain development. And this mature CNS baby, they sleep well. They sleep well. This allows the mother to get more uninterrupted sleep. This causes indirect effect on the mother's mental health. Now, what are the sources? Very good source is seafood. But for vegetarians, chia seeds, flax seeds, and walnuts. And also now the supplements are available which are made from microalgae. Other anti-inflammatory treatments we all know is the traditional antidepressants, and this is a herbal St. John's wort, which also acts as a antidepressant. So a small slide on not only mothers but sometimes the fathers also need support in for their good mental health. So 1 in 10 fathers get paternal postpartum depression. Up to 16% of fathers suffer from anxiety disorder during the perinatal period. So helping dads be at their best physically and mentally during early childhood has a big impact on their children's health. How? Such children are more ready for school. They have better vocabulary. They have better social skills. They are better able to regulate their emotions. So it also helps to increase both parents' confidence. It helps both parents be more responsive to their baby. It decreases mothers and fathers' potential for mental health issues. So we need to be as physicians, as doctors, should be vigilant about the symptoms around us, and early diagnosis and prompt treatment is what we are looking for. So, what the conclusion of today's topic is: inflammation is a key factor for depression. Inflammatory response system is triggered by both physical as well as psychological stressors. Postpartum mothers are at increased risk of depression because the inflammatory levels are high naturally in the last trimester of pregnancy, and this increase continues throughout postpartum period. Two important approaches which may prevent depression or decrease its severity: reduce the maternal stress, continue and support breastfeeding, as it is specifically anti-inflammatory. Reduce inflammation with the help of omega-3 fatty acid, with the help of exercise, with the help of herbal medications, and of course with our standard antidepressants. Research need to assess if anti-inflammatory approach, if it is used proactively, can it prevent depression from occurring in first place itself? A very vital question for today's discussion. So these are the references I've taken for my today's presentation. And if there are any queries, I can take in the chat box. Thank you for patient listening. Dhanyabad.
Thank you very much, Dr. Vidya Jadhav, for
Thank you.
delivering an important topic to us. So actually be with us till the end, because we will have the question answer session at the end of the program.
Sure, Dr. Arjun.
Okay. Thank you
Is my
very much for being
presentation
with us.
stopped?
Yeah, it's stopped.
Okay. Yeah.
Okay. So now I would like to request Dr. Preeti K to come on the platform to present your topic.
Am I visible and audible?
Yeah.
Yeah. Thank you, Dr. Arijit. Thank you all. I'm Dr. Preeti. I'm a child psychiatrist. I'm taking this opportunity to see what parents can do to improve the mental health of children. See, globally, the mental health issues in children is about 10 to 20%. This 10 to 20% is a very large number, and I don't think we have enough professionals to handle these disorders. I think it's important that we as parents see what can we do in terms of investment, in terms of investing our time to promote the mental health of children. So what I'll share over the next few minutes, I'll keep it very brief, is sharing some of my own experience as a child psychiatrist in a clinic, as well as a parent, to see how we can implement simple ways and simple techniques which are effective to see how we can improve our children. Now, see, as parents, most of us over the decades have learned how to focus on the physical health of our children. I think there's generally an improvement in the awareness of the nutritional status, the dental health. But however, I think we largely have ignored mental health. We don't particularly do anything for the mental health of our children on a day-to-day basis. Whenever I see this toothpaste ad, it always intrigues me because it is sold as if the beauty of the smile rests in the whiteness of the teeth. But somehow I think the beauty of the smile is in the mind behind it. A happy child will have a beautiful smile. I think it's important that we think more about or look deeper than what it is sold for. And I think we need to definitely do something to ensure that our children have a more joyful life. Few things that I would like to share is, one is to see, I think this time, this is a time where we have some time to pause and reflect and see what's happening really in our world. And I think this time what we need to do is to think and reflect, how much am I really emotionally connected with my child? And can I do something more? When we sit and think, we definitely will feel that there is something more that we can do. We may feel one way, but we should also see how much does our child feel they are emotionally connected to us. One simple thing that we can do as parents is spending quality time with them. See, when we say quality time, we recommend about 20 minutes of complete attention, positive attention to the child in an activity that the child chooses. Usually when I say this to parents usually say that I'm always with my child, doctor. I do their homework, I do everything for them, so I'm fully there with the child. When we say quality time, that's not what we're looking at. I'm looking at how much are we emotionally connected with the child, doing something where we can laugh together, giggle together, have some fun time, give them enough time such that they share what's happening in the emotional life of their of the emotional world of their selves. In the clinic, when I see, one common thing that I see is we as parents think a lot about providing things for them, worry about their future, but somewhere I always feel that somewhere the emotional connectedness of the parents with the children is simply not there. And the children also perceive that. I've seen many 11 and 12-year-olds say this to me that they wished that their parents spent more time with them. It often surprises that 11 and 12-year-olds share this with me, that they expect their parents to spend time with them. We often blame their gadgets. We say that it's because of the gadgets that we don't spend time, and they blame us. But I think it's important that we make this as a routine, that we do spend time with them. When you do this, I think it is very, very rewarding even for us, because all said and done, I think children are very important for us in our own lives. And so in some ways, it's also very, very rewarding for us as parents when we spend quality time with our children. So I think one thing that I would want parents to think really seriously about is to see how emotionally connected am I? And if there is an issue in their emotional world, will this child bring back that to me and then trust in me and then share that issue with me? That is something that we need to really think about. The next thing is, what can I teach my child so that the child can be emotionally healthy? See, during our corona times, we have seen that we taught our children how to wash hands, the 6 steps of hand washing, how to use masks, and how to maintain social distancing. And you'll be surprised that most of our kids really caught it up very quickly. The children have the ability to learn if only we focus and prioritize what is that we need to teach. So similarly, I think it is important that we also teach them problem solving skills. See, one thing that we did during the COVID is initially all of us panicked, but then later we tried and saw what are things that were under our control. For example, what can we do to ensure that we can prevent this infection? And that's where all these came into place: the social distancing, the mask, the hand washing. So similarly, I think it is important that we teach children when there is an issue, how is that they will see about what is in their control and to focus on the solutions rather than the problem. Culturally, we live in a culture where we talk about a lot about the problems. Oh my God, this happened, that happened. Maybe it would have happened this way, or maybe that way. So I think it is important that we help children have a solution-focused approach and help them in situations such as this to see about how to handle things which are under our control and not to worry too much about those things not under our control. I think the panic comes only when we worry about things which are not under our control. There are a lot of things which are, but thinking about them, worrying over them, only makes us overwhelmingly anxious. So I think it's important that we choose any situation, take any situation or experience, be it an exam, be it a test, be it a sport, to help the children learn about how to stay solution focused and how to look at things which are under their control to help them solve any situation. The next important thing that I see, which is different for them as compared to us, is that their experience is largely digital. While we cannot really influence the experiences around us, we can definitely influence the way we perceive it. So I think it is important that we spend enough time to see and equip them to face the digital world. For very young children, we usually set simple rules which might help young children, I would say. For example, setting up 1 to 2 hours per day rule, or setting up a rule such as downtime before 8 o'clock. Or laying simple rules like where would you watch the internet, only in the hall. Such things might work with younger children, but as they grow older, I think it is important also that we discuss about online safety with them. One thing that we notice is sometimes parents wonder, how do I really teach online safety? But what I see is online safety is not very different from offline safety. And so we need to help them understand the way we take time to make friends offline. I think it is important that we also take time to make online friends, that we wouldn't really talk to a stranger on the road. So is it in the online platform. Also, we do not really share personal information with strangers. So it is in the online platform. Such simple discussions in the home, I think, is very, very essential for children to know. Another important thing is about the digital footprint. that once I share a message or leave a image on the platform, even if I delete it later, it is going to stay there. So these are simple safety measures that we definitely need to equip them with. The other thing is about media literacy. I think a lot of us have read about media literacy. So we can definitely discuss those issues with them. But what I find very useful is take time and watch things along with them, be it the game that they play or the videos that they watch, and try to give them a different perspective from what they have about the video contents that they see. Not everything that is put there is exactly the same. So they need to definitely know and have a different perspective about the videos that they see. All that we can do is help them take informed choices. We may sometimes feel that, oh my God, if this internet or mobile wasn't there, life would have been easy for them. But we see that it's just there, and it's only going to be more and more because of the COVID, because of the online classes. And so I think it is important that we equip them in making informed choices. It's also important that we reassure them that whenever there is an issue like bullying at school, or be it in the online, like cyberbullying, we are there for them to help out. Sometimes I think as parents, what we often do is we are too critical or too quick to judge them or to criticize them or to say that, haven't I told you already? But I think it's important that we empathize with them and then take a stance of empathy so that they are willing to come back to us when they have an issue rather than go to a friend who might just say simple solutions of their age and then make the issues more serious. The next important thing, which I think parents should do, is take care of their own mental health. I think when parents take care of their own mental health, it helps the children in many ways because our parenting improves, our parent-child interaction improves, the family relationships as a whole improves, and we then become a role model because children learn largely by watching us. They don't really take our advices. In fact, they wouldn't care to do if we advise them. So I think it is important that we as parents also prioritize mental health. One of the issues that I find is not that we don't have the time. I think it is about that we have not really prioritized this. And we might simply say that I don't have this 20 minutes to spend every day. But I think if we set priority in our minds, we usually in psychiatry, we always say this, that if something has to come as a change in the behavior, there should be that change in your thought first. So I think we should bring it in our thought that mental health is definitely a priority in our lives, and it is definitely going to benefit us and our children. And this 20 minutes of time that we spend for ourselves and our children is going to be the most great investment that we can do to improve their own emotional health as well as ours. Post-pandemic, I think life is going to change, but I think it has also given us the time which we never had, the kind of pause that we never had. And I think in this time, I think it has definitely helped us reflect on a lot of things. And I think we should use this as a learning point to see how we can change our lives or improve our lives in terms of improving our physical and mental health, and not simply see this as another passing cloud. That is what I see. I would stop it here because I don't want to have a long lecture. If people have questions, I'll take it then.
Thank you very much, madam, for highlighting very important aspects of mental health. So, thank you very much for being with us. So, right this moment, I would like to invite our next speaker, Dr. Shatabdi Mitra, to please come on the stage.
Yes, sir, I'm on.
So, please proceed with your presentation.
Yes. Is it visible, sir?
Yes, it's visible.
Just one second. So very good evening, everybody. Am I loud and clear?
Yes, ma'am.
Thank you, sir. Good evening, everybody. I'd like to express my thanks to the Department of Physiology, especially Professor Arjit sir, for arranging and giving us such a nice platform for the observation of one-day awareness webinar on the World Mental Health Day 2020. And so I am Dr. Shatabdi, Assistant Professor, Community Medicine of Jagannath Gupta Institution of the Medical Sciences, West Bengal. Today I'm going to discuss, and it will be very brief, on community psychiatry. Is the screen moving, sir?
No, not at all.
Let me try just. Is it visible, sir?
Yes, it's visible. Yeah.
Thank you, sir. So the contents of the day for now are first brief prologue will be there, and then the community psychiatry, both global as well as for our national picture, need of the community psychiatry and the future directions. So the community psychiatry is nothing but, broadly, it is the deinstitutionalization of the mental health care for the people who are not to be told as the mentally ill. They have a big deviation from the so-called mental well-being, and they are the person who are the part sharing the common socio-demographic, cultural, and ecological characteristics of our community itself. And community, that means our society and our surroundings. They are our people. So the question comes, why the deinstitutionalization? To answer this question, first let's have a look to the global scenario. The lifetime burden of the mental disorder is 15% of the entire population, which is not a small figure. But the depression alone accounts for 5.1% of global burden of disease. We know that while we go for the assessing the disability rate, we use disability adjusted life year. And this disability adjusted life year is nothing but actually the years of the life lost due to maybe the premature death, maybe due to the long-standing illnesses. And this disability adjusted life year of the daily loss is more for the mental health conditions. Even it is more than the non-communicable diseases, which are the chronic disease conditions. And it is also supported by the statistics given by our World Health Organization. It shows that the unipolar depressive disorder, which in 2004 ranked third, it has been projected to come first in 2030. It's an alarming thing, of course. And the Indian perspective is not an exception. The lifetime prevalence of the mental disorders in India is 13.7%. And extreme disability is also high. If we have a look to this bar diagram showing the treatment gap of the different mental disorders. Treatment gap is there. That means that is the disease is there. We can identify the disease condition, and of course we have the treatment options. But by some gap, there are some gap by which we cannot reach the person who is at need. So there are some unmet need, and to bridge this gap, what is needed? That is to promote for the primordial and primary preventive measures. And the primordial preventive measures, we all know that these are the applicable for the people who do not yet have the risk factor. But still, there are some preventive approaches are there so that they will not develop the risk factor. As I'm just sharing one of my experiences, near about 1.5 months back, a small boy, an adolescent boy, aged 19 years, he visited the clinic with some complaint of being inattentive in his studies for last 1 or 2 months before the visit, and he was accompanied by his father and grandmother. Not only loss of attentiveness in the studies, he is doing bad. Once he is a student of a very good school in Kolkata, and once before this in the examination he stood first or second. But now he is doing not so good. And another thing is that he is not much interested in the studies. So while having some talk to him, I did not found so much thing. He told that he is not feeling well, and one thing is important that was that the time came to me, that this lockdown situation that is making people a bit depressed, a bit isolated. This kind of the things is happening. But later on, when on the third visit, just in the last Thursday, it was revealed that the boy has a problem family. In the family, his father is chronic alcoholic and beat his mother regularly, and of course him too. And these are the problems which he is facing from his early adolescence. But of course, the lockdown has escalated the problem. How? Because before this time, he was more busy with his friends, with his school, with his tuitions. But as the lockdown has started, he has to be confined in the family, in the house itself, and the problem is hitting him much. And so we have the activity to be started at the family level. And this, if the primordial approaches can be given at this level, family level, individual education, mass education, it will work. And of course, the primary preventive measures. That is the measures when the risk factors are there. That can be given for the young adults, for the early and the late adolescent children, and that have to be placed before the secondary level. Secondary level preventive measures, intervention measures will be there. But before that, the primordial and the primary measures have to be kept. And we have to give the stress upon care with a kind and tolerant approach at family and the community level. So here the journey began. The concept of the community psychiatry is not a new one. The era of the moral treatment brought by Philippe Pinel in France and William Tuke in Great Britain in mid-19th century. And since the early 20th century, William Jones and Adolf Meyer started the advocacy of the modern community psychiatry, which deals with the socio-cultural issues more, and then the preventive efforts, and of course the public awareness generation. And then Maxwell Jones, he brought the concept of the therapeutic community, and this therapeutic community is a very nice thing and a very nice concept, where the patient himself, the person suffering person himself, as well as his caregivers, are taken into the part of the decision making regarding the disease, regarding the treatment process, regarding the care support measures, and so that there is one collective responsibility. And it also gives the emphasis more on the rehabilitative services. And the Community Mental Service Act came in 1963. And this act encompasses, that is not only the OPD and the IPD care services, also takes the partial hospitalization, the transitional housing, and also the thing that is the support, education, and awareness generation among the caregivers. In the United States, the scenario currently is consisting of the things that will be also, I think, in details will be discussed in some by some other speakers. But there are the things like the group home, personal care home, natural family placement, satellite housing, independent living, and this community support program that came in 1977, years back. And this community support program takes a teamwork, that is the responsible team care activity. It takes also into action, that is the kind of halfway homes, then the provisions of the social and then the recreational activities, family and the network supportings. And in the Indian context also, before the independence, 4 Committee 1946 first drew the attention by reporting the prevalence rate and disparity in the bed patient ratio for the mentally ill persons. In 1959, Mudaliar Committee also emphasized in their report in the gap of the reporting system. We all know that the reporting recording system is a very important component of implementation of any program. And Srivastava Committee also recommended the community health volunteer scheme to meet the need. And the last words are, of course, told by the legislation. Government of India launched the National Mental Health Program in 1982. And to it, in 1996, nearly about 15 years after, the District Mental Health Program was added to this. And in the National Mental Health Program and, of course, the District Mental Health Program, there are the very important component besides the treatment of the rehabilitation and de-stigmatization, what Anirban sir was discussing very elaborately. That is, the stigma is very important for the mental health care support systems and also the awareness generation. So the community psychiatry acts in saving the resources, which is very, very important for the resource crunch settings like ours. Respite care. We all know that a mentally ill person, once get a bit cured, then become very much anxious or very much interested to go back to his own family. So if it is possible, once the emergency period is over, we can arrange for them the family and the community support. Then the adjustment and acceptance will be more easy. One thing we are all aware that once a person becomes mentally ill and get institutionalized for a long period of the time, the getting back to the community, getting back to the family, the acceptance become a problem. So the family and the community involvement helps a lot. It also gives the better rehabilitation in all the aspects, not only the medical, also the social and psychological also, and in the latter part also the vocational support. So following Robert Frost, miles to go. Community psychiatry still in its infancy in India. It needs the collaborative efforts and activities, not only from the workers and experts from the psychiatry and community medicine, but we also need the personnel from the different backgrounds, like us from the forensic medicine, from geriatric medicine, from, of course, from the internal medicine, then pediatric medicine, family medicine, and sociology. And then and there only we may have some holistic approaches. The way ahead and beyond, that is, there is need of the awareness generation to inject what is called positive philosophy of life on what can be done, in place what cannot be. So it is needed for the sensitization of the primary level of the healthcare providers Of course, also the traditional healers, because they play a very important role in providing the services, the healthcare service provision, especially in the rural community. And we have to depend on the broad shoulders of our frontline health workers. And then only we can make the evolving concept of the primary care psychiatry a reality. It is called the primary care psychiatry because you can see that inside it there is the amalgamation of the community participation. Of course, there should be the equitable distribution, then appropriate technology and intersectoral coordination. So our take-home message is deinstitutionalization, that is the theme and plays the pivotal role of the community psychiatry, is not a standalone approach. A scientific, sound, and well-oiled referral system, both horizontal and vertical, which should be effective as and when required, before, during, and after the institutionalization, is the backbone of the process. A pitiable awareness on the mental illness, brooming out the myths and the stigma, and living with disease. As in Dr. Anirban sir was telling that when we are accepting a person with diabetes, a person with hypertension, then why not a person suffering from some mental illness? So we have to live with the disease, and these are the only way to minimize the treatment gap and mainstreaming the persons who are suffering from some kind of the mental illness. So amalgamation of the mental health is with the primary health care is the need of hour. I am concluding by telling just a sentence, and I should tell this one, that this is the picture which was drawn by one of my MBBS students, of second professional MBBS student, just 6 or 7 months back, when after failing to fulfill her expectation in the first professional MBBS examination, she was suffering from severe depression, and she had a number of the suicidal attempts. I was once upon a time her mentor, and with our mentorship program that is currently ongoing in my institution, we took the responsibility keeping her in hostel. She stays in a hostel. She is hostelite. With the consent of her parents, we arranged for her treatment, care, and support. And today morning, just for today is the World Mental Health Day, she sent me this very nice picture, and here are two hands. Two hands we can see that holding each other. One is the hand of the caregiver, and one hand with a number of the intention marks. And just it's written down, I am not going to tell you to get over it. I am going to help you get through it. So thank you. Thank you all for patient hearing. Thank you.
Thank you very much, Dr. Shatabdi, for delivering a loud and energetic presentation. Thank you very much. So please be with us till the end of this program for having the question and answer session.
Thank you, sir.
So right this moment, I would like to invite Dr. Aniruddha Basu. Please come on the platform and please present.
Thank you. Yes, I am there. I would like to upload my presentation. Just a minute, please.
Okay.
Is my presentation visible?
Yes, it's visible to me.
Okay. So now it's visible and it is moving?
Yeah.
Okay.
It's moving.
Okay. So good evening, everybody. First of all, I thank Dr. Anirban and the organizers for giving me the opportunity to be here. I am Dr. Aniruddha Basu. I am a faculty at AIMS Rishikesh. I give the disclaimer that I do not have any conflict of interest. Yes, and today we had very nice and informative discussions. Now let's do a little storytelling and maybe a little guessing and some games regarding identification of figures. Like today, we all know that we are through a pandemic of COVID, but today I will tell you the story of a different pandemic. What it is? Any guess? For people who have been a little bogged down by, who have been throughout we had discussions about mental health, but it's nice to have a little guessing at times. If you are not guessing, let's do some identification of figures. Any guess who is this? This is Sigmund Freud. This is who is this? This many people might not know. This is the father of surgery, William Halsted. If you are not identifying this big figure, these big personalities, let's identify this person. We all know this is the god of football. And if you are not identifying these personalities, then we are all seeing movies. So what have you guessed that what is the commonalities among all these people? For all these men, drugs and addiction have wreaked havoc in their lives. If we go to the studies and read through them, we will all know. At least in some part of their life, might not be throughout. So now probably it's the time when we guess that when we come to know what is the other pandemic which I was telling about. The other pandemic is tobacco. It has been a pandemic since 1990s, and currently both these pandemics, we find that they are quite interrelated. For example, this tobacco use in people who are more of impaired lung function, the impact of corona is more. And for people who have like using more tobacco and those taking their mouth to their hands and mouth more contact, they are spreading more corona. So there is a bidirectional relationship. Hence, we need to understand and addictions, particularly tobacco and corona, and the relationship and how we can deal with them. It's not only tobacco, but there are other common addictions which are in our society and country, which a recent study has found out, which consists of tobacco, definitely alcohol, the others are cannabis, like ganja, bhang, charas, etc., and opioids, heroin, and other things. Some people might have seen the recent Hindi movie like Utta Punjab, and those things where opioids were exemplified. One person may say that how much is the prevalence? Is it too common? Yes, it is quite common. We have 16 crore alcohol users, of which 5 crore users are problem users. And cannabis users, we have 3 crore users. For opioid, we have 2.5 crore users. It is not a big amount. 2.5 crore is almost the population of some of the European countries, like Portugal or some other smaller European countries. But it is not all. It's not that all who are just taking this heroin, opioid, there are other common behavioral addictions also. Common among them are the internet gaming addiction, particularly, which has quite increased in the recent days. Now, you can test yourself that whether how much probability you are having addiction. If you are looking at the screen, you can just download this Young's internet addiction scale, and it is there are multiple versions. I have downloaded this 12 version for you. There are questions like online, how much longer than intended you are on, whether you are just a few days or just a few more minutes when online, you always say yourself, do you neglect household chores? Do you cut down the amount of time you spend online and then fail? Does your academic performance, or for people who are not who are doing some job, your job performance decline because of the time you spend, or you lose sleep because of being late? You just click onto your handset for that. So also, and you rate all the questions based upon this: never, rarely, sometimes, often, or very often. And the other questions are whether you spend more time online and overgoing with others, whether you hide, how many time you have been hiding from your family members, whether you snap, yell, or get annoyed if someone others bogs you down when you are online, or you feel depressed or moody when you are online, or you feel preoccupied with the interest when offline, or fantasize about, like, you are always thinking, even when you are offline, you are always thinking, when I'm online, I will do this, I will do that, and you become defensive or secretive, hide your device in front of family members, and you rate them accordingly, like never, nearly, sometimes, often, very often. It has been seen that in such scales, you can do it later, you can take the snapshots and other things, or you can just download Young's internet addiction scale. You can see that you can see the result was that problem users who score more than 30, pathological users who score more than 37 or 38, some of the studies shown. So who is at risk? It has been said that common studies has been said there are many studies related to this that shown that in a study among 1,000 around 500 these young people, it has been shown that 34% are mild and 8% they are having moderate internet addiction. The figures are quite alarming. We need to, for this reason, we need to understand more about this phenomena of addiction. What does addiction actually mean? How does it happen? If we see, and we need to also understand that whether or we are at the individual, we are at risk or not. Look, a total population, not everybody, if everybody uses internet or everybody uses tobacco, it is not that once a while, it is not that everybody develops an addiction to that. For example, people who have ever tried, some of them, this is proportional to the size of the circles. If you see total population, only a small amount will have ever tried. Small amount, it is also not small in that sense. Around 40 to 50% would have ever tried, of which 20% would have developed problems, of which say 5 to 10% have developed dependence. Dependence means addiction and severe problems. And what factors determine this transition? The factors which I will be discussing: biological, a combination of biological, psychological, and social problems. Biological problems, for example, heritability. Heritability means genetics, whether addiction, people using alcohol, tobacco, or other addictions, or some instances are there of this and other addictions also, whether they are in your family. For example, in your family, even if people are not around, a father whom I have never seen, if he is addicted to some drugs or substances, I also have a lifetime risk of having the thing in my life. And a vulnerable age group, our brain is constantly maturing from the age of 10 to 16 years, or this early adolescence, which is say, this is a very critical period. During this time, the chances of addiction and the addiction harming our brain are the highest. So at this time, what happens is that this young mind, 10 to 16 years, at this time, we have a very powerful accelerator. Our brain is always working to do new things. Our brain is very active. But at that time, we have breaks. For example, we are not able to handle ourselves. When friends come, when peer pressure happens, we are not able to handle ourselves. And this is the time when if we saw something, if modeling or this happens, there is a large imprint on our brain. You can see that this is a soft of sandy clay beach. If it remains for some time. But when a person grows up, say a person of 40 or 50 years old, he is not that vulnerable to external influences. Also, there are psychological factors. For example, there are exam stress, as there are anger, emotionality, and the idea to have enjoyment. Enjoyment. So this combination of this psychological and social factors, often we have peer pressure, friends coming and say, let's try it once. Why don't you try a little tobacco or a little alcohol one day? It will not do any harm. People have that. And also there are other factors, social factors, like we see often in movies and these celebrities and other people taking. So we think that why not we experiment? So it is a combination of biological, psychological, and social factors that often lead to addiction, which is nothing except a alteration in the brain, which can be conceptualized as alteration in the brain chemicals, and that leads the hijacks the normal brain functioning. And how to prevent that? People may say that how should we prevent that? So we have just discussed that how these factors combine to cause us this people who have ever used or ever experimented. So one easy way is not to experiment at all, not to experiment at all. But we all know that our life is not that easy. We tend to often experiment, we tend to often and try new things, because that is often the need of life. So what to do at that time? Because adolescents, many of here, I think, presume they are students and adolescents, they have a very powerful accelerator, their brain. You please imagine your brain to be like this car, where there is a very powerful accelerator. But we grades, people who are students, who are passing through these developmental stages, adolescents, 16, 17, this time, you are very creative, sensitive, and unstoppable in your own goal. That case, it's you can, if you devote yourself to activities which nourish your brain, exercises which are considered to be positive, addictions, or different and creative hobbies, that often decreases the risk of developing harmful addiction. Lifestyle modification, choosing a structured lifestyle, that often helps us. But what to do? But if a person who's using drugs, or say addictions, or say any other, like say tobacco or whatever it is, what do you do? When a person asks, I just revert back the question, what do you do when a patient has high blood sugar or blood pressure? Because nowadays, addiction, the alteration in the brain chemicals, is understood just similar to blood sugar or blood pressure. You treat, you help the person. It might be, initially it might be self-help. Nowadays, in this era of corona, people are hardly visiting hospitals. They are helping themselves. There is a national quit line number for this tobacco. Please note down, people, if anybody who wants to help others. There is this Alcohol Web India, where is this alcohol use disorder identification test, online test you can take, and you can see what where you lie. Or you have the national toll-free drug addiction helpline. This is by Ministry of Social Justice and Empowerment, Government of India. These helplines you can see. You can do online assessment, and if you feel that the problem is more, these things are not helping, you can seek treatment. All government hospitals and other things, you can encourage people to seek treatment. All government hospitals nowadays are psychiatry department where this sort of help is being taken. Now, since tobacco is one of the commonest addictions, a patient, you can just help. You can ask the person to have a quit date, and you can ask him quit immediately. You can take the help of nicotine gums. It is the 2 mg gums are available without prescription in most medical stores. And please remember, these nicotine gums are quite effective, but people often use them as bubble gums. It's not to be taken like that. There is a proper way, which is the chewing and parking method. You can just log into one of the YouTube videos and see how you need to use that. If you use that the proper way and proper time, you need to use it every 2 to 3 hours, so that your brain is repleted with nicotine and you do not feel the hunger for that. And other things, when we have mostly craving for this tobacco and other things, when you have hunger, when you have anger, when you have loneliness or tired, this is known as the HALT, HALT. We need to avoid this. And if still we have craving for this tobacco, we need to have this 5D, like delay, distract, deep breathing, drink water, and discuss your problems with family members. Often that just, and a little lifestyle modification, like sleeping at the proper time, taking food at the proper time, maybe some relaxation and other physical activity. And if not, then we cancel professional help, or medical colleges and most of the big hospitals have psychiatrists nowadays where they can give online consultations. So we need to know about our addictions, and we need to treat. You need to treat your addictions if you find them problematic, as addictions are like other medical conditions like diabetes and hypertension. And with this, I wish everybody a happy mental health in this World Mental Health Day. And please invest a little more time to your mental health and access help if required. With this, thank you.
Thank you very much, Dr. Aniruddha Basu, for delivering a wonderful session on addiction. So please be with us till the end for having the question answer session. So right now, I am requesting our next speaker, Dr. Shilpa, to please come on this platform.
Shilpa, you're mute. Shilpa, unmute yourself.
Sure. Sorry. Can you hear me now? Can you see the slides?
Yes.
I'll start my presentation.
Yes,
A very
please.
good evening. A very good evening to all the listeners. I'm Dr. Shilpa Pathar. I'm a consultant psychiatrist from Mumbai. At the outset, I would like to thank the organizers for such a wonderful and enlightening seminar and for giving me an opportunity to be a part of this seminar. Today, I'm going to speak about stress and resilience. Firstly, what is stress? I would say any stimulus that makes my body respond to it is a kind of stress. We are exposed to various pressures from the outside, and stress is our body's response to those stresses. Right from when we were a student to adulthood, we have faced and handled various stresses. So, is stress really that bad? What if we had no stress at all? Well, low stress situation would be like a balloon with no air inside it. Without stress, there is no excitement, no stimulus. So we would be leading a very lethargic, dull, and unenthusiastic life. Optimum stress is also called as eustress. Just the right amount of stimulation will help us to lead an energetic, successful, and a positive life. However, excess stress would be like overinflating that balloon. It is bound to burst. This excess stress is called distress, and it causes disappointment, failure, and embarrassment. A quick walkthrough about how our body responds to stress. A brain is a master conductor who plays the symphony of our body's orchestra. Reaction to any stress is through our brain. It stimulates the secretion of hormones like adrenaline and cortisol, which causes bodily changes like rapid heart rate, rapid breathing, increased muscle tension, slowed digestion, and increased blood pressure. This first stage is also called as the alarm reaction and causes either a fight or a flight response. So either we stand and face the situation or we run away from it. It all depends on the circumstances that we are in. The second stage of stress response is the adaptation phase, where the body adapts to the long-term stressor the bodily hormones are still elevated, and so the resultant bodily changes are still going on. The third stage is the stage of exhaustion. The body systems are depleted, and the body can no longer handle the stress and succumbs to the various stress effects. So, what are the effects of the prolonged stress on the body? Prolonged stress causes our brain to have the effects of low concentration and low energy, headaches, dizziness, panic, depression, and anger, increased heart rate and blood pressure, leading to increased risk of cholesterol and heart attack. It upsets our digestive system, leading to acidity, pain ulcers, change in appetite, and weight gain. Chronic stress suppresses our immune system, leading to illness and high level of inflammation. Stress causes frequent joint pain, body ache, backache. It reduces the bone density and protein breakdown. Stress also affects the sexual function. It decreases the hormone production, leading to infertility and decreased sex drive. So, in the past, we were always taught about managing the stress. Okay. The old model of stress management focused on all these things to reduce our stress. So, the focus was on reducing the stress or avoiding stress. These methods are still helpful and should be practiced to improve our general well being. But there was a need to focus on some other ways to improve the stress handling capacity. Let me tell you a small story. Once there was a big oak tree in a jungle. It stood tall and strong, and it used to always laugh at the little grass near its foot, telling that you bend with even the slightest wind, you are very weak. One day there was a storm in the jungle. Heavy winds blew and knocked off the old oak tree. Now the oak tree lay on the forest floor, and the grass, which had bent upon the winds, now stood up. So, this is resilience. It is the capacity to bounce back from the life's inevitable disappointments, failures, and pain. Imagine yourself traveling in a car without any shock absorber. Well, we would feel every bump and every pothole on the road, and our ride will be miserable. Well, resilience is our internal shock absorber. It helps us to have a smooth ride throughout our life. Of course, there will be adversities in the life. Major life events like death of a loved one, loss of a job are difficult to cope, and we may require external help to cope with them. But for minor life events like start of the school, beginning of a new job, assignment deadlines, etc., it is our resilience that helps us. Do you know who are the most resilient among us? Well, those are the small children. Have you seen a toddler learning to walk? It falls down several times, but gets up each time and takes a step forward. Just like this favorite toy of the kid. No matter how many times we knock it down, it bounces back up. So to say that we are born with resilience would be correct. But as we grow up, we lose some of this capacity. So why is it important to be resilient? There are certain characteristics of resilient people which makes them more successful in life. They see problems as challenges. They have their goals and are committed to achieving them. So instead of lamenting over things that are not in their control, they focus on things that are in their control. They take responsibilities for their actions and don't blame others. They are emphatic and positive people. Most of us know about this Maslow's pyramid, which depicts our need. We need to go from the base to the top, fulfilling each level at a time to progress to the next level. So, if a person must first fulfill his physiological need, the roti, kapda, and makan, and then he can progress to the safety needs and have an intimate relationship. And once that is secured, he works on his self-esteem and then reaches self-actualization, which is a state of morality, creativity, spontaneity, and a state of well-being. Well, resilient people have turned this pyramid upside down. They are creative, spontaneous, empathetic, and ready to work for the community, even if they have not met their physiological or the safety needs. So, in being emphatic and working towards the community, they have met their self esteem need and belonging needs, and the community then takes care of their safety and physiological needs. Let me now take you through the steps of being resilient. The first step, whenever you are faced with a problem, is to get a perspective of the situation, and you should observe that situation objectively. You should ask questions to yourself: how bad is the problem? Is it simply amplified because of my past experiences? Next, we need to ask ourselves, what is the worst thing that can happen in this situation? Many times, the answer would be not the worst thing that can happen is not that bad, or it is very unlikely to happen. We have to compare the undeserved bad things. Many times we blame ourselves. Many times we blame the situation. This is so bad. Why do bad things keep happening to me? I don't deserve. I'm such a good person. Why should bad things happen to me? So you should make a comparison chart of all the bad things, that undeserved bad things that have happened to you, to the unearned good things. Unearned good things, that you are born in a good family, you have been given a right to education, you have a roof over your head. So make a list of all these good things that have come to you naturally without working towards them. So if we make a balance sheet of all these good and bad things in our life, we will realize that maybe things are not so bad after all. However, it may happen that the situation would be bad. We may be bombarded by problems from all the sides. Your health may go down, there may be problems in your work, there may be problems in the family, with your relationships. Problems can be everywhere and anywhere. Well, we just need to toughen up and face them. The earlier one starts to toughen up, it's better. Many times parents cuddle and protect their children from all the bad things, but actually they are doing them more harm than good. So how do we toughen up? We need to push ourselves out of our comfort zone, accept challenges, and face them boldly. You will be surprised to find that you are stronger than you think you are. Each man is the architect of his own fate. In that, it is not the circumstances that he can control. Many times, the circumstances are not in our control. What happens in our life, maybe it is not in our control, but how we react to it, how we react to those situations is totally in our control, and it is this reaction of ours which will mold our future. Right now, we need to take a personal inventory of our life. If you are facing problems, take an inventory. Think about all the problems that are there in your life. There may be drinking problems, there may be relationship issues, there may be work issues, and there may be academic difficulties. Well, how much of these problems is being contributed by you yourself? Once you realize that to avoid those behaviors, the ability to change your life lies within you. An emotionally resilient person is a competent person. He knows how to handle difficult situations, and he has confidence in his abilities. He maintains ties with his loved ones. Just because he's having problem, he doesn't, cut off all the ties. He maintains ties. He maintains the communication with his loved ones. He has a strong set of values, and he uses his strength to help others. He has a better way of handling stress, and he knows he has the ability, and he has the capacity and the control to make choices in his life. So now I call upon you to bring out your inner strength, bring out the inner superhero in you. It is inside you, bring it out, and it will help you manage stress more successfully. Thank you.
Thank you very much, Dr. Shilpa, for delivering an excellent and encouraging presentation.
Thank you. Thank you for the opportunity to speak to such an august gathering.
Thank you very much. So we witness till the end for the question and answer session.
Yes, yes,
So
of course.
right this moment, I would like to request Dr. Rajarshi. Uh, he is from United Kingdom, our international speaker on this platform. So I'm requesting Dr. Rajarshi Dash, please come on this platform.
Thank you so much. Can you hear me? Am I audible and visible?
Yes.
I'm trying to share the presentation. Should I be sharing the entire screen or?
Yes.
Okay. Is my presentation visible?
Yes.
Just a minute. Is it visible now?
Yes.
Is it moving?
Yes, moving properly.
All right. Yeah. Thank you. Yeah. A very good evening. I'm Dr. Das. I'm one of the consultant old age psychiatrist. I work in.
You can please make it in full slideshow mode.
Okay, full slideshow. Okay. Just a minute. Is it okay now?
Yes.
Is it full slideshow now?
I think it is not in the full show mode.
Is it now for showing full slideshow?
Yes, you need to click there.
Is that okay?
Okay.
Is it moving?
Okay, moving properly. Yeah.
Yeah. Okay. Yeah. Hi, a very good evening. I'm Dr. Das. I'm one of the consultant old age psychiatrists. I work in Southwest Yorkshire NHS Foundation Trust. I thank Anirban and Arijit for giving me this opportunity to present in this webinar. I've kept it a quite generic. The main presentation has been with old age psychiatry, the concept of old age psychiatry and how we need to care our roots. So that was a kind of presentation. So I've kept it a bit generic. I'll take the questions after the end of the session. As we all know, today is the World Mental Health Day, and the main theme is obviously the theme that it's greater investment and greater access. We are not celebrating it. We are trying to make ourselves heard that we need much more investment in terms of our mental health, and we want all the people in every aspect of our society to speak up about their mental health. If we look into in our country's data, we have got the Mental Health Care Act bill that was it was in 2017 when it came up, which guarantees mental health care and treatment, which is funded by the government. But unfortunately, we could not see that much more in this current scenario. I think we are still spending around about 0.05% of the GDP in mental health, whereas developed and other countries are spending roughly about 3.5 to 3.6% of the GDP. So we can see how small we we are spending in terms of mental health, and we need this kind of a more spending in order to get a more equitable distribution of mental health throughout our country. By saying that, I start the content goes like this. I'll briefly discuss about the demographics of elderly population. I will try to give some case vignettes, the geriatric mental health, why it is the need of the hour, what is aging, what age do we say that it's a cutoff point for elderly population, what are the common mental health problems that we encounter in old age. I'll briefly touch on depression, old age, especially old age depression. The most important thing is dementia and other neurodegenerative disorders, delirium, what is delirium, and other mental disorders that happen in old age. I will also touch upon on elderly abuse and the challenges that we are facing at the moment with geriatric mental health care. And at the end, I will just touch upon the caring for our elderly and parents. Yeah. So this is the current scenario in India. I got it from one of the newspapers, and it shows that right now in India, it's 6% of our population is more than 65 years of age. So you can imagine if it's 1.39 billion. So the old age population is roughly about 84 or 85 million. And if you can see the graph, it's gradually increasing worldwide. It's an aging population, we all understand. And with aging population, there are challenges. There are demographic challenges, there are economic challenges, there are technological challenges, and there are social challenges as well. So we need to, because of this rising elderly population, there are changing social norms. So we need to meet their needs and demands, in order to have a good effect on not only on the physical health, but also on the mental health. So the projection in 2050, if you see, it's about 20% of our population will be elderly care. So it's a need of the hour that we should focus on geriatric mental health at the moment. So as I said, it's now 6%, but it's targeted at 20% in future. I'll start with the case vineyard. It's quite interesting. I see so many patients. I've just haphazardly mentioned one of them. He's a 72-year-old gentleman living alone. The children stays in different cities. They work in ITs. They work in IT cities. Before retirement, this gentleman used to be a very active person. Developed loneliness, especially after his wife's death. There are comorbid physical health issues. He suffers from diabetes, hypertension. He has got some glaucoma. His mood deteriorated, especially after a friendly neighbor. He had a very good relationship with his neighbor who died from cancer. And he started getting worried about his physical health. He repeatedly tries ringing up his children that he feels physically unwell, leading him to have, and the children came over, took him to hospital, all thoroughly investigated in a multi-speciality hospital. Nothing acutely abnormal in terms of physical health. Then he started believing that he has got cancer in his tummy, as he feels constipated, becomes gradually tearful, develops a poor sleep and appetite, expresses suicidal thoughts that he doesn't want to be here anymore, starts reducing his fluid intake so that he can die, again needing hospital admission. So at that time, he was referred to a psychiatrist by the treating physician. So the reason why I put this example is, see the complexity of this gentleman. So there are so many dimensions in this example. The next example is a 68-year-old lady who has been living with her husband. She has got no psychiatric history in the past. There's a gradual onset of 2 to 3 years of history of forgetfulness of memory, which is going downhill day by day. He used to be a fantastic cook, but gradually lost skills, sometimes forgetting to switch off the gas cooker, leading to burning of food. She has been misplacing items, accusing husband that he's taking away her utensils, started getting very agitated without any reason, significant carer stress with her husband and unable to cope. Again, you can see the complexity, so many dimensions are there in this case. So after this case, vignettes one, I'll come to this point that geriatric mental health it's a need of the hour in our country. So as I said, I've shown you two examples. So it's quite unique and it's kind of a separate expertise to detect. You need an early detection. You need to treat that problem and you need to care for that problem. Caring is not only in terms of medication. Caring is something which is multidimensional in nature. So the elderly patient suffers from mental health problems, often has a combination of what we call a psychological, physical, and social needs. So as I said, it doesn't mean that individual assessment, management, and follow-up requires a varied collaboration between not only social healthcare, but also social, voluntary organizations, and family carers. Well, in developed countries, you do have the social services which are very well developed. But in India, we need to have those kind of like voluntary organizations, or family takes most of the responsibilities. So it's kind of a collaboration that we need to work through with elderly care. So you have to understand the principles in their identification and management. That should be an integral part, like primary care, social workers, or any health workers. We need to educate them about what's unique in geriatric mental health. Right. So again, I said, why do we think it's very different? It's quite different from young populations, or we call it ageless populations, because there are so many complexities and comorbidities with physical health. There are issues with mobility. They have increased risk of falls. There are fractures, osteoporosis, leading to further complications. So when you prescribe something, when you prescribe a psychotropic to an elderly people, you need to take into account of these complexities and comorbidities. There will be drug-drug interactions, and obviously old age physiology is quite different. So when you are choosing a drug, you need to be very, very careful about the dosage, the pharmacokinetics, and the interactions with other drugs. Another aspect is understanding the neurodegenerative disorders, mainly the dementia. That's quite different because obviously in young age, although there are some cases where we see young onset dementias, but neurodegenerative disorders are quite different. You need to have the expertise. You need to have that experience in order to detect it quite early. And plus, another important thing is the social factors: post-retirement, lack of meaningful engagement, housing issues, financial factors, transport problem. We are not in nuclear, we have developed nuclear families. We are not extended families anymore. So children are living far away from our parents. So that's also an important factor to look into old age psychiatry. So that's why this subspecialty is quite different. So what's old age? Well, if you look into the colloquial or definition of old age in Britannica, it says the progressive physiological changes in an organism that leads to senescence or a decline of biological functions and of the organism's ability to adapt to metabolic stress. So it is more of a kind of a biological or physiological meaning of old age. But is it so? Well, as I said, it has got so many factors, so many dimensions. There are physical dimensions, there are social dimensions, there are spiritual dimensions as well, where we say it's aging. The most acceptable age is 65. So most of the countries in the world, they have a cutoff of 65, where we define as elderly population. In India, I'm not sure. It looks like 60 because that's the retirement age. So might be I think 60 is in India. Some countries in Africa, they have 60 as the cutoff. But as I said, mostly 65 is the cutoff for elderly person. Now, if you say 60, age is not only a cutoff, but the need changes as well after 65. As I said about the dimensions, the physical health, the social dimensions, these things change as we grow old. So, well, Erickson, who is Erik Erikson, who has been the famous psychologist, psychoanalyst, I should say, he has said about the development of human development, and he says old age as a stage of integrity versus despair. And what is integrity? When you reach at an age after retirement, you reflect upon back that what you have attained, what you have gained in your life. The completeness, like you had a very good job, maybe you had children, so it's a sense of a completeness is there. And then there is despair. This, because after 65, you are coming to the age where your mortality is an issue. So you're having the despair in life. And also said there are some despair, like some things in the past which you have not done well. So these things comes into your mind. So Erickson says that it's a balance of the integrity and despair that flows you through this stage. So it's a nice concept. If people can have time, can look into Erickson's development, especially with this stage. Some say this is the 8th development stage, as far as I remember. There is no other stage after that. But some post-Erickson people have stated there's a 9th stage as well. But I think that's a very good example at how we reflect upon our past in this age. Yeah. So, what are some of the tips for how we should stay very healthy? I tell to all my patients, stay mentally and physically very active. Keep a positive attitude towards life. Always eat a balanced meal. Including fruits and vegetables. Include fish. This, what I'm saying, is all evidence based. Include fish in your diet. Reduce salt and sugar. Increase fiber intake. Always make sure you are hydrated. Take regular exercises. Walk. Another aspect is, I always tell my patient, is practice sleep hygiene. With age, your sleep, the quality of sleep actually reduces. So I always tell them to practice sleep hygiene. I don't prescribe regular hypnotics or sleep medication to them. I always go through non-drug interventions before prescribing anything. And as Anirudh was saying before, avoid smoking, alcohol, and any substances, and always keep your brain stimulated. That actually increases our brain reserve. If you do crosswords, any Sudoku, number games, anything that always improves our cognitive reserves. So, saying that, what are the common mental disorders? This is part of my own experience that I have gathered. What are the common mental health disorders that happens in elderly population? If you see globally, the data is about 15% of old age populations suffer some kind of mental health problem. I was looking into Indian data, but I could not get any specific available epidemiological research there. But it says that some studies are saying 8 to 60%, but I think on an average it should be like 30%. So it's definitely, because obviously we are a bigger country, we have a huge population. So the mental health, the epidemiology of mental health will be much higher as compared to global population. So I think we'll roughly say it's around 30%. But what are the common mental disorders that happens in old age? Absolutely, depression is number 1. Number 2 is dementia and neurodegenerative disorders. It takes about a quarter of the elderly population, suffers from dementia. Anxiety disorder, alcohol-related problem, as Anirudh was mentioning, it is a problem, and especially with the pandemic, and delirium as well. Other mental health disorder that we see in old age is late onset psychosis. But from my experience, this late onset psychosis, if you follow them up for a few years, they usually develop a neurodegenerative condition. And in UK, the prevalence of depression in old age is roughly about 22 to 28%. So you can imagine, as somebody was mentioned, one of my previous speaker was mentioning about DALI, disability adjusted life years. So you can imagine if depression is around about 30%, the DALI will be so high. So what are the characteristics of late life depression? It's quite different from a young population. As I mentioned, there are some risk factors, like there will be physical health factors, social issues, isolation. There can be memory problem underlying. There can be financial issues as well. It is usually underdiagnosed, I would say, because it is not recognized properly in the primary care level or hospital setting. as the manifestations are quite different. So they end up going to the GP or a physician, because they mainly present with more bodily symptoms like abdominal problem, pain, complaints of forgetfulness. Some people present as agitation, and I have seen, elderly people who have been having extreme worries, but they're smiling. So it's quite weird, how they present in old age. And as it progresses, it will present with some paranoid thoughts. Like the commonest theme that they present with, they say that their house and money being taken away, they start feeling very guilty and they can start hallucinating. So this is quite unique in old age depression. Another thing to remember is elderly depression has a very high risk of suicide. So if somebody is harboring any suicidal thoughts, that should be taken very, very seriously. They end up doing anything. That's my experience, and I have been through a few of them. And because they don't realize that they're depressed, so that's why they don't take professional help early. And when they present with psychiatrist or a professional, it's so late, it has gone so late, and so difficult to treat at that point of time. And obviously with depression, there is an increased risk of physical health deterioration. We all know the cardiac status and other parameters are all interconnected. So anybody having a depression, if they have a heart disease, the morbidity is quite high. So how do we treat late life depression? As I said, because it's multidimensional, it has got so many factors. So we need a very holistic approach. We always follow a biopsychosocial model of treatment. So what's biological? We treat with psychotropics. So what psychotropics like antidepressants, but picking up an antidepressants is very, very crucial because you have to look into the underlying physical health. You have to look into any previous problem with that medication. You have to look into the drug-drug interactions as well. Say, for example, if you are prescribing an SSRI to an elderly people, look into whether that patient is on aspirin or not for the cardiovascular disorder. So if they're on aspirin, and if you are prescribing an SSRI, you need to make sure you put them on a proton pump inhibitor, like an omeprazole or whatever it is. So that's why I'm saying it's very, very important to look into the medical history when you're prescribing something for late life depression. Psychological therapies, as mentioned before, CBT extremely helpful if they can cope, obviously, if they are psychologically minded. But from my experience, elderly people, they are not keen in this kind of talking therapy. They are more prone, oh, can you give me some medication so that I can get better? The other part is like social integration, voluntary organization addressing social issues, which are also an integral part of treatment. From my experience, what I've seen that this late life depression is sometimes an early precursor of an evolving neurodegenerative illness. I always tell my patients that continue antidepressants lifelong. There is no point. If you stop it, you'll get a relapse of your depression. Although there are guidelines that, they say that after 9 months you can stop it. Some say after 12 months you can stop it. If you stop the antidepressants, relapse. Right. We'll briefly touch upon cognitive disorders. Now, there are different types of memory problem that can happen in old age. One we call it mild cognitive impairment, and the others are dementia. So how to differentiate between a mild cognitive impairment and a dementia? Well, mild cognitive impairment is a condition when someone is having some minor problem with their cognition. So you must look into cognition and memory are not the same. So there are multiple areas of cognition. So there are minor problem in their memory and thinking, which are worse than that is normally expected for a healthy person of their age. Say at 65, at 70, obviously you will not have the same memory as somebody in the 50s. So they will have some memory problem, but if it is more than expected for a healthy person, then it is not, the symptoms are not severe enough to interfere significantly with their daily life. So that's called a mild cognitive impairment. But if it is affecting significantly their daily life, then we say it's a dementia, right? So there are memory tests where we can objectively say that it is cut off. If you look into the international memory test, like over here we do the ACE-3 tests. So there are cutoffs, obviously, but simple cutoff is not enough. So we need to look into the memory problem, whether it is affecting the day-to-day functioning or not. Unfortunately, mild cognitive impairment, we don't prescribe anything, as researchers have shown that it actually worsens the situation. The main thing is lifestyle modification, reduce stress, and as I said, keeping your brain active. Next is dementia. Person with dementia will have cognitive symptoms, as I said, with thinking and memory, but they will often have problem with some of the following areas, like day-to-day memory. Yeah.
Sorry for interrupting you.
Yeah.
You need to share your screen again.
Oh, is it? Oh,
Yeah.
is that all right? Sorry. Is it now showing?
No.
Resume slideshow. Yeah.
Yes.
Is it showing now?
No, not resuming the slideshow. You need to resume the screen sharing.
All right. Okay. Let's see. Okay. Okay. Resume your presentation, isn't it?
Yes. Yes.
Is it resume presenting?
Yes.
Is it now okay?
Yeah.
Yes,
Okay.
sir.
Okay, okay. It's all problem of a webinar, isn't it? Because I'm not used to the Google Meet. I've been doing it over MS Teams and Zoom. So anyway, is it visible now clearly?
Yeah. Visible.
Okay, yeah. Okay. Am I in the 15 slides? Is that dementia slide? Is it visible? Yeah.
Yes. Yes.
Okay. Okay, sorry about that. So a person with dementia will, as I said, will have problem with their day-to-day memory, they have problem with their concentration, planning, or organization. For example, as I said, difficulties in cooking or day-to-day activities, solving problem, or any sequential tasks. They can have problem in the language. For example, they can have difficulty in, finding out the right word for something. They can have problem in speaking or understanding as well. Other areas are like, we call it visuospatial skills. For example, judging distances, such as the stairs, and seeing objects in 3 dimensions. They can have problem with orientation. They can lose track of their day or date or become confused when they go out. And a person with dementia will often have changes in their mood. They can be, some people can be very apathetic, withdrawn. Some people can be quite agitated. So as I said, the crux is a memory problem, areas of cognitive symptoms, plus affecting the day-to-day life. That's dementia is. Now, dementia is always a clinical diagnosis. It's not with like we do an MRI or a CT here and we say it's a dementia. No, it's not like that. History, collateral information, proper memory test, and a neuroradiological investigation. They all contribute, then you come to a diagnosis of a dementia. So it's nothing like, as I said, you look into diseases and you diagnose a dementia. No, it's always a clinical diagnosis. And that's why I say it needs a bit of expertise to detect early this kind of dementia. Okay. What are different types? You all know that Alzheimer's dementia is the most common dementia worldwide. Second most is vascular dementia. There are some other dementias like Lewy body dementia, Parkinson's dementia. Mixed dementia is a combination of Alzheimer's and vascular. Others are frontotemporal, alcohol-related brain damage, and there are some rapidly progressive dementia, which I don't want to mention it over here. But commonest is Alzheimer's vascular. There are some increasing trend of this special type, what we call it, a Lewy body dementia, which is beyond the scope of today's discussion anyway. Unfortunately, dementia is a progressive condition. There is no cure. It's just some medication which can halt the progression of the disease. So again, treating dementia is a holistic way how you do it. So drugs are one part, anti-dementia drugs at one end. But as I said, it should have a holistic care. Like the person with dementia can have social issues. They can have financial issues. They can have physical health issues. So we need to look into all those issues as a psychiatrist. talking therapies can help when they are in the very early state of Alzheimer's dementia or in an early stage of vascular dementia. Sometimes talking therapies help, like reminiscence, going back to stories from the past. This thing helps. The most important is person-centered care. So the key points of a person-centered care, I always like to mention this, that treat the person with dignity and respect. Understand their history, lifestyle, culture, their preference. Look at the situation from the view of that person with the dementia, not as us. Look into from their perspective. And provide opportunities for the person to have conversation and relationship with other people. Even if it's a dementia, you can't say, oh, your memory is gone, why are you speaking? No, that's not the way. Encourage them to speak up, encourage them to interact with other people. Ensure the person has a chance to try new things, maybe some activities, maybe some gardening, whatever we have. Family carers and the person with dementia should always be involved in the care plan. Whenever you try and treat a dementia, always make sure that the family and carers are involved in their care, in the care. And their knowledge and understanding of the person is extremely valuable to make sure the care plan is right. Okay. Now, there are some evidence-based of alternate therapies with dementia. Over here, some care homes use aromatherapy like lavender oil, lemon balm. These are all the helps in relaxation, reducing anxiety. A bright light therapy, some people use it for sleep-wake cycle problem. There is no evidence for cannabis, CBD oil. Coconut oil, still lacking evidence. Transcutaneous nerve stimulation exercise. Well, some patients with dementia can have pain where this transcutaneous nerve stimulation can be of help, but evidences are still poor. But important is the study finds listening to music increases brain cell connectivity in Alzheimer's disease. So that is one interesting research. So I always recommend people with Alzheimer's dementia to listen to music. Pet therapy, well, it is a bit controversial because if the dementia is advanced, whether they can take care of the pets or not, it is difficult to say. Another dimension is developing behavioral and psychological symptoms of dementia. As I said, about 90% of dementia patients will develop behavioral and psychological symptoms. The common symptoms of agitation, the example that I gave in the case Finiart. So agitation, anxiety, restlessness, these are the common symptoms. As the dementia progresses, they develop these symptoms. And always non-pharmacological interventions is the first approach, as using medications like psychotropics in dementia increases risk of stroke, risk of falls, and so many things. Say, for example, if a person is pacing, wandering, and agitated because he's just bored, he's just lonely, and we just need to provide him some meaningful activities. So psychotropics are only indicated when the drug fails. Okay. Another thing is delirium. We tend to, it's difficult when in acute medical settings. Sometimes we miss delirium. It's a worsening or change in the person's mental state that happens suddenly over 1 or 2 days. The person can become confused, drowsy, or sleepy. So there are two types. We call it hyperactive delirium and hypoactive delirium. Or sometimes there's a combination of both hyper and hypoactive. It's called a mixed delirium. It is a medical condition and hence needing treatment of the underlying condition. So commonest what I have noted in old age delirium is UTI, urinary tract infection, chest infection, or recently COVID has increased. It's, as I said, quite often missed in general hospital settings, and the psychiatrists are usually called for assessment because the patient is psychotic. No, it's not psychosis, it's a medical problem. Anxiety disorder, it's nothing different from young age. Like they can have a generalized anxiety, like simple things, everyday occurrences and events, or they can have some panic attacks. Treatment is the same as with adult anxiety, but they mostly have comorbid depression or a possible underlying cognitive disorder. Another is elderly abuse. I was looking into one of the Times of India snapshots. We said 73% of Indian youth admit their elderly abuse exists. 53% are mainly related to property and inheritance disputes. And 61%, the main abuser is daughter-in-law and son. So the forms of abuse are mostly verbal abuse, neglect, and physical attacks. So current research is evidence suggests that 1 in 10 older people experience elderly abuse. And because of this abuse, there is a very high prevalence of depression, anxiety, and it paves the way for social isolation with increased risk of suicide and emotional devastation. So I think as a psychiatrist, if we encounter an elderly abuse, we should take appropriate action. I don't know how there is POCSO Act in child in India, but I'm not sure whether there is any such acts which have came up in India at the moment. So briefly looking into the challenges in geriatric mental health care in India, as I said, there is a demographic challenge, 6%, which is a huge population to look into for elderly care. There's a heterogeneity of clinical presentation because of this cognitive, physical health issues and all this complexity. There are challenges for dementia care, especially, as I said, need expertise to detect, treatment, not only in terms of medication, but also the psychosocial aspect, which is a real challenge for dementia care, like looking into the burden of the carers, like home care, social care, or a day hospital, something like this, which needs to develop. Socioeconomic factors is a problem, like if you see the elderly population, like I think 80% is in the village scenario, and it's more difficult to have equitable distribution, of healthcare over there. Rehabilitation facility is an issue for elderly care. Nowadays, I'm not going to name anything, but HelpAge India, and I think there's a private care which have developed in and around Calcutta, but at the expense, obviously. We need to push our government to really have some rehabilitation facility. As I said, lack of detection in the primary care level of elderly depression and dementia. Sexual health of elderly is almost, not told as whenever we take any history. There's elderly abuse, and then end of life care, which is also an important aspect, in geriatric mental health, because there is no point when somebody has got an advanced dementia or an advanced cancer to put him or her in a ventilation when we know the life expectancy. So that's another area which needs evolving. Just a few points about caring for your parents. Assess your parents' needs. You need family support, home safety, medical needs. You have cognitive health, mobility, personal hygiene, meal preparation, social interaction. Take a step back and understand what the needs are for your parents. Also think about your own needs and ability. We want our parents to be safe and healthy, and it's not selfish or heartless if you're not the best person to personally provide that care. By looking for that health and safety and arranging the help they need, you will be being a more supportive and caring child. Always include your parents in the decision-making process. Understand the financial situation, both yourself and your parents. Take care of the home safety, basic home safety, like in the kitchen or the bathroom or in bedroom. If there is any trips and falls, there is something that can increase the trips and falls. Make sure when you communicate with your parents, it's simple and accessible, and explore if there is any care options or not. I end my presentation by quoting Maggie Cohn, who is an activist from America, who said, "Old age is not a disease, it is a strength and survivorship. Triumph over all kinds of vicissitudes and disappointments, trials, and illness." So at the end, I will say compassion, empathy, respect, dignity, support, and a helping hand, and of course, safety for the elder health. That's all for today. If there is any questions, I'm happy to answer, or they can put me in the chat box. Thank you.
Thank you very much, Dr. Rajashri Das, for addressing geriatric mental health issues. So now I would request our participants to put your question in chat box if you have any, and also requesting all the speakers to have a look in chat box. Someone is asking that can meditation keep our brain stimulated?
Yes, of course. Yes, yes. There are very good researches. Meditation. We always promote that, we call it mindfulness. So meditation and mindfulness, of course, it increases one's brain reserve, and there are good researches as well. Yoga, keeping us. It's all part of keeping us physically and mentally active. So definitely, yeah, I would encourage people definitely.
Thank you for addressing this question. Dr. Akshay Hawal is asking that, sir, can you tell me what is old age?
Well, as I said, it's kind of an cutoff age is there. There is nothing like, in a colloquial meaning, I've already mentioned, it's more physiological. But there's a cutoff age, we call it 65, when the needs appear a bit different worldwide. There are studies which shows that after 65, the needs appears different than when adult. As I mentioned about the social, physical, mental, and spiritual ends. So it's different. So, but there is nothing like crude definition of old age. Some people at their 70s may say, well, I'm very young. And some people say, for example, if somebody have got an early senescence
Yes.
at their 50s.
Actually, as a biological marker, I think there is some
Yeah.
correlation between old age and the telomere length shortening.
Exactly. That's more of a biological concept, telomere shortening. Well, obviously, it has got some effect on our brain as well, isn't it? Neural pruning and everything happens. We have to accept that. But there is no like a classical definition. There was at some point a push for need-based services. They were saying that over here in UK they were pushing from old age to ageless services. But then from the Royal College, we have made it very clear, because there are so many dimensions, so many complexities, there should be a separate subspecialty. So it's very difficult for an adult psychiatrist to treat, and there are legal issues as well. So it's very, very difficult. So that's why we have kept this specialty, as something separate.
Okay, understood. So I think there is no more question.
Okay. Somebody said, is any type of dementia involvement of trace elements metabolism?
Okay.
Can he clarify a bit? Involvement of trace element dementia? You mean dementia from trace element deficits? See, there are some reversible causes of dementia. For example, B12 and folate. They are quite common. So when we do a dementia screening, there are specific blood tests that we always request. So that includes a B12, folate, thyroid, everything. So trace elements, well, there can be, some they can present with cognitive impairment, but as I've already explained, what is dementia? Dementia is an umbrella term. It's not only just memory; it affects so many things, activities of your daily life. So there is another question: any risk factors seen in adulthood which can be prevented, then, so that mental health is sustained? I think risk factors mean stress, as already mentioned. The stress and resilience, like one of my previous speaker did speak about the stress and resilience. So I think that is one of the factors which can be prevented. But it's quite unique, it's very difficult to say whether you can develop. Okay, cooking in aluminum vessels causes dementia. There's another. I think, yeah, heavy metals. Heavy metals, yeah, there are some studies about heavy metals and aluminum causing dementia, but as I said, they are very rare causes of cognitive impairment.
Sir, I have a question.
Yeah.
Hello.
Yeah.
What are the sir? Can I? I am audible.
Yes,
Yeah.
please proceed with your question.
What are the neurodegenerative changes occur during dementia?
Neurodegenerative changes in the brain, you mean?
Yeah, in the brain.
Yeah.
During dementia or in mental phase. What are the degenerative changes occur during mental stress and dementia?
Okay. As I said, dementia is a neurodegenerative condition. There are specific areas in the brain. It depends on which subtype of dementia you are looking into. Say, for example, if it's an Alzheimer's dementia, the neurodegeneration will start from the hippocampus. And what we look into is hippocampal atrophy and the medial temporal lobe atrophy of the brain. So there, it starts from there, and then it progresses towards a global atrophy. So it starts in the hippocampus, medial temporal atrophy, the ventricles get enlarged, then it moves upwards. Then you get a parietal atrophy of the brain, then you get a frontal atrophy of the brain, and then a global cortical atrophy. So that's how dementia sets in. But this is for Alzheimer's. But if you say it's a vascular dementia, then it's a stroke-related dementia. So it happens where the strokes, where the stroke has happened. So mostly what we see is around the basal ganglia region, or the MCA territory. We call it MCA territory, middle cerebral artery territory. So we can get those infarctions there, and then the changes happens there. Whereas Lewy body dementia, it's kind of a other type of dementia where you get Lewy body deposits in certain areas of the brain, mostly in the subcortical region of the brain, and also sometimes it can be cortical. So as I said, it depends on which type of dementia it is. And with stress, I think, as far as I remember, I think my previous speaker had spoken to, stress increases neuronal pruning, as far as I remember. So maybe if you get continuous stress, there is a risk of neurodegeneration in the future. But the specific areas, maybe amygdala, again, the region of the brain which deals with your emotions. All right.
Okay, thanks. Lot of thanks for your excellent expression. Okay, sir, I have also another question. I am actually very enlightened for your answer. So I have a lot of questions, but I only one question told you that. My question is that what is the molecular mechanism behind of the molecular mechanism behind of the short-term memory to long-term memory, and what are the effects when we are suffering from chronic mental disease?
Okay, are you mentioning about it's the second messenger system, the molecular level? I think that's yeah. So definitely, as I say, it's if it's stress or any depression or anxiety, it can affect the second messenger system, isn't the protein kinase C and the calcium influx. So those are the areas, yeah. But in neurodegeneration, well, it's previously the concept was amyloid plaques, plaques causing this problem. When the plaques are getting deposited, there are amyloid precursor proteins, the APP. Okay, the gene is expressing those proteins, and those proteins are causing this amyloid flux. But the concept now have a bit changed. They are more changing towards proteinopathies now. So rather than the flux, they are mentioning about the protein. So that's why the researches, in the last 50 years, the researchers have been more towards this amyloid precursor proteins and the amyloid plaques. That's why we didn't get some good drugs, but now the researchers is moving towards neuroinflammation, towards proteinopathy. Uh, so that's where the molecular level stands at the moment. Okay, but still very unclear.
Okay. Okay, sir. Lot of thanks, sir. Is there is any relationship? Uh, is there is any relationship with Alzheimer's disease?
With what? Alzheimer's disease with what?
Alzheimer's disease actually how much related to trace actually,
Yeah,
and
yeah. Stress is definitely, as I said, stress is definitely a factor for any neurodegenerative condition. All right.
Yeah.
So the more
Stress
than
is a
the
silent killer.
yeah. So that's why
yeah,
we whenever we are treating a dementia, Alzheimer's dementia, we always mention to the to patients that to reduce stress or give medication if there is significant stress or anxiety. So definitely there are. Okay, so somebody is asking if
okay,
PET
okay.
scan is a diagnostic test for old age dementia. Maulik Devnath, very interesting question. Well, PET scan is a very expensive scan. We only do it when there is a diagnostic dilemma. When the diagnostic dilemma is, for example, we want to we are like the threshold. This the memory test score is like marginal, like 82, 84. And the patient is functioning well, but still complaining of memory loss, or we want to differentiate between a frontotemporal dementia and an Alzheimer's dementia. So in those instances, we do a PET scan, but remember, PET scan can give false positive results. So we need to make sure that if it's a significant diagnostic dilemma, then we do a PET scan. There is no specific diagnostic test for dementia. It's a clinical diagnosis always.
Okay, thanks, sir. Lot of
Okay.
thanks.
Thank you very much to all. So due to time restriction, we need to close our session here.
Okay.
So on behalf of Department of Physiology, Mahadevananda Mahavidyalaya, I express my gratitudes and thanks to all our eminent speakers for delivering such fabulous lectures to us, and for enlightening different aspects of mental health issues. So thank you very much, and we will join again sometime. So let
Thanks.
us hope for the best.
Thank you. Thank you for a very
Thank
interesting
you,
session.
Orijit. Thank you. Should we give a good round of applause for Orijit?
Thank you very much.
Thank you. Bye.
So we'll see you again. So
Thank you.
bye.